along with Sharon. Okay, awesome. And it's being recorded. I totally forgot about that. Thank you. And I will let our lovely trainer and panelists introduce themselves. If y'all want to go ahead, whoever wants to go first, just let us know your name and your job position, because I know we have a counselor, nurse, and a dietitian. So if you could just introduce yourselves briefly, we'd appreciate that.
I'm happy to go first. My name is Lauren. I am a registered dietitian nutritionist. I currently work with the eating disorder population, and I have been since about 2017. I work both in outpatient settings and within treatment facilities. So happy to be here. Thanks for having me.
Thank you.
Hi, everybody. My name is Dr. Emily Horton. You're welcome to call me Emily. I have a PhD in counselor education and supervision. I'm a licensed professional counselor. I currently work as an assistant professor at the University of Houston Clear Lake, but prior to that, I was a clinical director for a residential treatment center for adolescents with eating disorders.
Thank you.
Yeah, thank you.
Good morning, everyone. I'm Christy McVeigh. I've been a registered nurse for over 30 years, long time. Background, emergency department, a little bit of everything would come through there. And probably for the past 20 years, I've focused on quality. I'm currently a chief of quality management in a hospital. And so do get to review a lot of different issues, health equities, those types of things within our community and within our facility. Glad to be here.
Thank you so much for being here. Okay, so to get us started, I'm going to share our screen, share my screen. I do want to apologize. I don't know why my word is on dark mode, and I don't know how to fix it. So I'm going to read it out loud, and we'll turn it over to our panelists after that. Okay. Maybe how do I share this? There we go. Can everybody see the screen? Yes, okay, I saw some nods. All right, so this was a case study that we got from a peer-reviewed article. So there's going to be some medical things, and there's going to be just like a whole bunch of integrated healthcare setting stuff. So we some of us might not fully understand it. Like I know I had a hard time reading or understanding what the vitals and things meant, but bear with me while I try to read some of the words, but I practiced. So MR is going to be our client. So MR was a 14-year-old Muslim Kurdish student living in Sulmania, northeast of Iraq. His parents were of an educated middle-class family who enjoyed good health and stable relationships. He was brought by his mother to the hospital on July 18th for refusing to eat, which had led to severe weight loss and generalized weakness. His condition began 7 months prior when his friends teased him about his plumpness and greedy appetite. Consequently, he started restricting his food intake, avoiding high-calorie foods, and indulging routinely in extensive exercise. His parents tried to convince him to eat regular meals, but he refused. He was obsessed about his body shape and measured his waist and thigh circumferences regularly. His food intake decreased rapidly until his daily meal became no more than a cup of yogurt and pieces of cucumber. A few weeks before his visit to the hospital, he experienced severe fatigue, headaches, joint aches, and attacks of epigastric pain, followed by vomiting. He was treated by the local doctor with multivitamins, antiemetics, and antispasmodics, but without improvement. The patient seemed to be overprotected by his mother. He was the youngest of 7 siblings and a clever boy. She described him as being a graceful and obedient child, but somewhat of a perfectionist. There was neither a history of physical or mental illness nor sexual abuse during childhood. Okay. So on admission to the hospital, he appeared to be severely ill. He was pale, emaciated, and dehydrated. He had lost about 44 pounds during the past 4 months, according to his mother, who reported episodes of irritability and depressed mood with the decrease in weight. His body was 62 pounds and height was about 4'8", which is below the second percentile for his age according to the growth chart. His BMI was 13, reflecting a 37% deficit in weight for his height. Upon examination, he showed generalized muscle wasting and his skin was dry and covered by lanugo hair. His chest was clear and he had a scaphoid soft abdomen. His blood pressure was 90/60, heart rate 55, and body temperature 37.8 degrees Celsius or 100 degrees Fahrenheit. Lab tests were as follows. So they checked blood glucose. This is where it gets a little for me. Blood urea, serum sodium, creatine. They checked cholesterol, platelet count, and they described blood proteins were low with slightly elevated liver enzymes. The blood culture was negative. They did some thyroid function tests and steroid hormones were normal. General urine examination and culture revealed an acute bacterial infection, which accounted for his fever. Skull, spine, and chest x-ray, brain scan, and abdominal ultrasound were all normal. A previous gastroscopy at another hospital showed mild mucosal atrophy, and ECG revealed sinus bradycardia. The patient was smaller and shorter than his matching peers. He looked attentive but indifferent to his serious condition. His speech was rational and did not reveal delusions or hallucinations. However, he expressed strong denial of his body appearance and insisted he had a normal body shape. His mood was depressed, but he denied suicidal ideation. Okay, so he was admitted on the 18th of July to Solomania General Hospital and was referred later for psychiatric consultation. A liaison treatment plan was designed by the attending physician, psychiatrist, and dietitian, focusing on scheduled feeding under the dietitian's advice, which was to be achieved through a nasogastric tube. Caloric intake was measured to reach 2,000 calories per day, and he was instructed to rest in bed under a nurse's supervision. This ameliorated his previous hypoglycemic attacks. He was prescribed oral cephalosporin, 250 milligrams to treat his urinary infection. On the second day of his admission, the psychiatrist prescribed 20 milligrams a day dose of fluoxetine to treat his depressed mood and food-related obsessions. A 5 milligram nightly dose of olanzapine was prescribed to resolve the distorted thoughts about his body image and promote sedation. Nasogastric refeeding was continued for the first week in the hospital until oral feeding was established. The tube was removed on the 6th day. In addition, a few sessions of cognitive psychotherapy were conducted with the patient. At the end of the 3rd week, he became more realistic and rational about his body weight and was more compliant with eating normal meals. His mood and irritability improved. He was discharged after 24 days in the hospital, advised to abide by the regulations of the dietitian and continue his medication for 3 months. He was to report to the psychiatry clinic on alternate weeks. His body weight had increased to 30 kg, which is 66 pounds. He did not keep his appointments and appeared 6 months later at the clinic weighing 84 pounds. He was enjoying better health, although he was still having eating peculiarities. He had maintained his daily exercise, but was reluctant to gain more weight. And after consultation, he was advised to continue on fluoxetine for another 3 months. The family was advised to escort him regularly for psychotherapy sessions and watch his dietary intake. So pause. And now we'll move on to our questions. So just with this format, I'll ask each question and whoever wants to chime in first, please do so. And then we'll just continue on from there until there might be some questions from students at the end if there's time. So for our panelists, based on the information provided, what diagnosis or diagnoses would you give MR? And what would be the symptoms within the case that support those diagnoses?
I have 2 diagnoses for him, starting with anorexia nervosa restricting type with some further evaluation for purging based on the previous vomiting. Restricted intake leading to significant low body weight, which is shown by the low BMI based on age, intense fear of weight gain, disturbance in the way the body shape is experienced, denial of serious of weight loss, undue influence on the body weight. And my second diagnosis would have been severe protein, calorie, and malnutrition, And this would have been more along the lines of a physical exam, but some of these criteria would have been obvious significant muscle wasting by the noted emaciation, loss of subcutaneous fat, and nutritional intake less than 50% of the recommended intake for over 2 weeks, bedridden or otherwise significantly reduced in functional capacity, and weight loss over 2% in 1 week, 5% 1 month, or 7.5% in 3 months. And it was estimated that he lost about 40% of his body weight in 4 months. So he meets that criteria as well.
Thank you.
I agree with the diagnosis of anorexia nervosa restricting type. For the mental health side, it sounds like the client could also meet criteria for major depressive disorder. And so given if with the information that's provided, I think that's an assumption that could be made, including the depressed mood, not reporting SI, but the overall depressed mood and being bullied by peers and so on. It seems as though there's some symptoms that might indicate that there's major depressive disorder in addition to the anorexia nervosa restrictive type.
Thank you.
And I'm a nurse, so I really don't do diagnoses, but definitely as a nurse, you would be able to see symptoms that would support each of those diagnoses as previously discussed by my 2 peers previously.
Thank you. Okay, so we'll move on to the next one. So what other formal or informal assessment might you use in your session to support this diagnosis? So any further information and how you would get it?
I'll go first if that's okay. As a nurse, I think it's really important to do a detailed assessment. So it would include not only a detailed social history and really asking, making sure you're not asking just really broad, open-ended questions. I mean, you might start that way, but eventually you would want to start to hone in and try to get more detailed information from their responses of your questions. I think I would do a lot of watching of interactions. I'm thinking he's 14, parents are probably in the room, so I would want to watch what those body languages are, how that relationship is going, any of those visual cues, and really paying attention when I'm asking questions during my assessment. Who's responding? Is maybe the mom, who's noted to be overprotective, is she answering everything on his behalf? And is there a way that maybe I can elicit him to answer more for himself? And perhaps at some point it may be where I would see if the parents would be okay with leaving the room so that he could maybe have an opportunity to speak more honestly, maybe whether it's fear or something else going on with him. And then I'm thinking, again, as Reddy talked about, maybe some type of just screening for depression or anxiety, something along those lines.
Absolutely. I totally agree with Christy in the sense of, assessing for more family system and their ability to support MR outside of the hospital, right? Especially because we know that he left at a certain weight and came back again, without following up on his appointments and continued weight loss. So there seems to be some maybe lack of social supports there. I would also do follow-up lab values. So I would want to know about his testosterone, his thyroid, CBC, phosphorus, vitamin D, glucose, to see how he's maintaining his nutrition. A DEXA scan, so that's a bone density scan. Due to the significant weight loss and prolonged low intake, there's a high possibility of some bone loss or some bone compromisation. So EKG or echocardiogram just to monitor the heart rate. 55 is probably a little bit low for where we'd want to see a 14-year-old boy, even with the kind of athleticism exercise. Doing kind of that nutrition focused physical exam. So kind of the things I mentioned above, where like you're looking at the muscle wasting, the fat loss, edema, even examining hair, nails, skin, for more physical signs of nutrient deficiency. And then a dietitian's work in the hospital versus outside the hospital is a little bit different. So in the hospital, this would more fall under, a therapist job, but outside the hospital, I would definitely be looking into frequency and severity of the eating disorder behaviors, and continuing to sort of assess the physical and emotional well-being of the client while he was under my care.
Yes, and I love everything that's been shared. That interprofessional collaboration is so critical in doing this work. And I always love hearing that we're all thinking similar things, but we also have our unique specialties. It's really fun and brings me back to the work. From the counseling side, in addition to what's been shared, a pretty traditional biopsychosocial intake interview and really talking through the biological, psychological, and social factors. In terms of more formal assessments, I love using things like the EDEQ or the EDI-2, which are eating disorder assessments that give you more information about the eating disorder behaviors. And from the depression or anxiety side, things like the PHQ-9, the Beck Depression Inventory, the Beck Anxiety Inventory, the GAD-7, any of those assessments that the client might be willing to do, in addition to the biopsychosocial intake interview, to have more of an understanding of all of those elements, would be really helpful and would support the diagnoses.
Okay. So our third question is, what treatment would you implement with MR, whether it's the same or different as what's in the case study?
I'll just chime in. I think from a nursing perspective, it would be important during those follow-up visits, sessions with MR and his family, just to follow up on the treatment plan. Is he taking his medications as prescribed? Tell me a little bit about what your daily meal plan looks like. Trying to marry it up again with what's been prescribed for him, and trying to get answers as to the compliance with those things. And maybe, maybe they'll tell you, well, he's not taking this medication. And then that's your opportunity, would be my opportunity to say, well, can you tell me a little bit about what's making it difficult to take this medication? Sometimes you find out it's they can't afford the medication, or maybe it upsets their stomach. So maybe you could work with the prescriber to find out about changing the times when the patient's taking those medications. So really trying to get to a state of what are barriers to them being fully compliant with prescribed treatment plans. So that's what I would look at. Again, always following up on those vital signs, looking at that assessment again. Am I seeing improvement? Am I seeing just overall improvement of condition?
Yeah, treatment right now especially tends to be along the lines of starting at the lowest level clinically indicated and sort of seeing how the client does there. Versus I feel like even 5 years ago, pre-COVID, it would have been like you kind of do the highest level clinically indicated to try and hit it hard and fast. So I would suggest an FBT model, which is family-based therapy. So the family is doing primarily the nutrition management and making sure that he gets his meals and kind of watching out for the social and psychological cues, with support of an outside team, ideally a dietitian, a therapist, and continued medical monitoring. However, if the family continues to not be able to meet those things, unless Christy's like saying, trying to make them more accommodating, trying to figure out better times, but if they continue not to be able to meet or engage in those appointments, I think more support could be indicative, and that's to help the family, right, to allow them a break if there's family burnout, or to get them kind of more information, more understanding of kind of what is going on in their son's care. So I would start in more of an outpatient and then kind of titrate up as needed.
And based on what was shared with us, if I understood correctly, it sounded like they were doing bi-weekly individual counseling. And from my perspective, it feels as though more like weekly individual counseling would make sense. And that could take different approaches. Like oftentimes eating meals during the therapy and doing meal support is an uncommon experience that I could see making sense for this client. I also saw that they mentioned doing cognitive psychotherapy with this client, which may or may not make sense. From my experience, sometimes when a client is experiencing the myriad of medical symptoms that we are seeing here, cognitive therapies may or may not work because sometimes they experience more of like a brain fog and they can't access that part of their brain. And so trying to do reframing of cognitions doesn't work with someone who is malnourished. And so it might take a different therapeutic approach. And also, I would love to do family therapy and parent consultation with the family and have them be active participants. In an ideal world, it would be great to do individual therapy with him on a weekly basis, weekly family therapy, weekly parent consultation sessions to talk with the parents about how to support their child. But depending on a lot of logistics, that ends up shaking out differently.
Yes, I agree. I think given the age, parent involvement, family involvement will be absolutely crucial in the client's ability to continue on a trajectory for recovery in this instance, but you know.
Thank you. Okay. So question 4, how would you include other professionals to provide treatment in an integrative approach? And what resources might you also believe to be helpful for MR?
All the folks we can get to help are the benefits over. I mean, I love working with dietitians and nurses and the PCP and the psychiatrist and the school, if applicable, to really have that full holistic wraparound care with as many folks and make sure that we're touching on all of the different symptoms and needs for this client. There's a lot of different resources that might be helpful for him. Some of the ones that are standing out to me most are, given his age, oftentimes adolescents in that age range are all about social media. And so one of the things that we might be doing is going through and maybe cleaning out his phone and removing the things that aren't so helpful for the recovery process and adding things that are more helpful in the recovery process. And so I have lists of social media pages that are helpful for the recovery journey, as opposed to adolescents might often have lots of things that aren't so helpful and can be very activating for eating disorder symptomology. And so that might be one of the primary resources that I would start with is social media options.
I completely agree. The more people you're able to get involved in a cohesive team, the better. Some maybe resources that might be helpful is during the nutrition sessions to do nutrition education. So talking about the whys around food and how it impacts your body, especially for kiddos who are perfectionistic and academically inclined, right? They kind of want to know the whys. They want to understand what is going on with the body, and sort of doing some counseling in that way as well for the family too, right? To understand why the carbohydrates are just as important as the protein and the fat, and why a diet in varied food types and food groups is important and how that impacts.
For CE.
A few other interdisciplinary professionals you might want to include, maybe again pharmacy, maybe getting pharmacy depending on what those meds are. And I think Emily spoke about school, involving school counselors. I mean, there may be an issue that they need to bring up and do education school-wide regarding bullying or body image. There's so many things that the schools could offer. And then thinking about resources, I even thought, what about peer support groups for MR? It was already talked about family therapy. And I go back to thinking about him just kind of missing in action for 6 months, didn't come to any appointments, those types of things. If that would continue to be an issue, perhaps bringing in someone to do some case management, which would have more frequent contact with the family, doing those reminders, hey, you've got an upcoming visit, don't forget, this is important. It kind of to help guide them and navigate them through this entire process. So just some food for thought.
Awesome. So moving on to our last couple of questions. So question 5, what suggestions do you have for novice professionals to be mindful of with MR when treating eating disorder symptoms? And what are some cultural considerations for treatment as well?
In terms of the nutrition component, I think that there are a lot of cultural considerations, and also just as some advice, you're not going to catch everything, right? Like that's why we have interdisciplinary teams, that a therapist might talk about like, hey, have you noticed that they're scared of this, fear food that, that didn't even kind of register on during your sessions or your radar. So you're not going to catch everything. And that's why being a part of a team is so important. But in terms of sort of like things that you might want to consider, I've kind of noted some religious restrictions. So like fasting, right? Or avoiding specific foods based on their religion and how to be culturally sensitive, and also, assessing, are they in a place to be able to engage in those things? Food security. So the financial and environmental ability to access adequate nutrition, is that a barrier? Views on health. This is really important in the family system, right? How do they view food? Are there a lot of good foods and bad foods, and foods that are kind of demonized or not kept in the house, and sort of how like you're going to work around those things? The social, impacts, right, of food in the culture. Many cultures and religions have a lot of holidays and celebrations sort of centered around food. So how does that impact, the client or the family? And I know the client didn't endorse any trauma, but sometimes, big T trauma, right? Like really significant singular or perpetuated events, like, oh, nothing like that. But hearing over and over that, you're pudgy, or you're eating too much, or you're greedy around food, like those kind of little T trauma things can really build up, and how the client is responding to those things will also be sort of an important consideration for the treatment.
Things that I think about also is we all have a bias, whether we want to recognize it or not. We all have biases. So just staying mindful, whether you're talking with the family, you're talking with MR, you're talking amongst each other as professionals about those biases, and trying to make sure we are aware of them enough to where we can still provide the best quality of care in the treatment for him. And to me, I always go back to this. I guess it's from being in the emergency room. I'm a very visual person. So as I'm talking to the patient, the family, I am so cued into verbal cues, to what's being said versus what their body is doing at that point in time. So be mindful of that. actively listen. Don't listen to give a response. Listen to understand and use that to your advantage for those teaching opportunities. That's when you're going to cue in that they're really interested in this. Maybe it is about the nutritional components, and being able to take those cues and step in and use that to educate family or the patient or other professionals. As said earlier, we all come from different professional backgrounds, and sometimes we pick up on things that others of us have just missed. It was there all along, but until somebody verbalizes that and puts it out on the table, we're just not aware of it. Thinking about cultural considerations, definitely what was spoken about, the religious holidays, food avoidances. Also thought about, he's a teenager. So a lot of times these kids get up right before they got to head out the door to go to school. There's no breakfast. They're not eating breakfast. So thinking about foods on the go, that would be an opportunity for him to choose. And then also thinking about the socialization of food again, but with the peers. And so are they all going out and eating French fries and full sugared Cokes every day, those types of things. And then being able to say, you don't have to completely pull away from those social interactions, but let's talk about being prepared. How are we going to be prepared when those situations arrive, and what can we order from the menu that are healthier choices for him? So those were the few things that came to my mind.
And there's been a lot of really beautiful things shared so far. Just to add a couple of more thoughts, one of the things that I think is important for novice professionals to consider is this balance between staying within your scope of practice so you don't cause harm, but also recognizing that there are far too many people in mental health professions who say things like, I don't work with people who have disordered eating or eating disorders. And so to be able to grapple with and distinguish that fine line, of course, you don't want to cause harm by not knowing what you're doing, but also if only people who have the certification in eating disorders saw clients with eating disorders, there would be large amounts of people not getting treatment. And so to grapple with that balance there is something that's really important for novice professionals to be mindful of when they're working with clients with eating disorder symptoms. You can't just refer everyone out. There's not enough people to refer out to, but you also don't want to cause harm. And I think a lot of beautiful things were shared in terms of cultural considerations for treatment. One of the other things that I was thinking about that comes up often in my experience working with clients from different cultures and different religious backgrounds is the cultural beliefs and familial expectations around food. Like some cultures might have the belief that in order to show respect to your elders, you must finish everything on your plate. And if not, that's disrespectful. And so there can be a lot of cultural expectations regarding food and intake that can be part of the treatment process, is really exploring those in your initial intake interviews and throughout the counseling process to understand how culture impacts them in lots of different intersecting parts of their identity, but including their relationship with food. Because maybe noticing and honoring their hunger cues is really hard because they were brought up in a family and a culture where things like respect are more important than honoring your hunger cues. And so that can certainly be part of the conversation as well.
Thank you. So our last question is, in your own profession, what personal example can you share regarding clients with symptoms of eating disorders?
I think more recently, we're really trying to shy away from this idea that eating disorders have a specific look, right? Like if someone cannot have binge eating disorder who isn't in a certain body, or anorexia, right? If they're not in a certain body. So I think, although like weight loss, weight changes, all of that is a great indicator, sometimes it's not always like a tried and true indicator. I would say one of my biggest indicators of sort of an issue around food is the rigidity, right? The idea that like, no, I cannot eat that, or I cannot eat that much, or I cannot eat it that often. You know, taking a bite of something, picking it up with your hands, sort of like those like a little bit of smaller cues that might not scream out at you right away, like if you're kind of sitting, you know, in a group together, but just a little bit more nuanced, I would say.
All right. I when I look at this and I think about some patients with eating disorders, I think about them coming forward. There's got to be, I'm thinking myself, there's got to be some level of shame maybe over their current situation, and also maybe this loss of control. Lauren just talked about the rigidity, and so there's probably this battle going on with people. So I would just say again, it's so imperative to be non-judgmental, be aware of your biases, just really work on earning their trust. There is so much they could share, but they have to be in an environment of safety where they feel safe to share that information. And I think once that can be obtained, I think that they could make great strides in overcoming and learning to deal with whatever the disorder is, and make healthier choices for themselves.
And in addition to what's been shared, this question had me thinking about how eating disorders often thrive in secrecy. And sometimes it'll be pretty clear that someone is struggling with an eating disorder, and sometimes it won't be as clear because sometimes you can't always see it, of course, like what Lauren was talking about. And there can be a lot of secrecy. And so it's really important that you're thoroughly assessing all of your clients, in my opinion, for any symptoms of disordered eating or eating disorders so that you're aware of them, especially when it comes to adolescents, for example. We would see things like people didn't realize they had an eating disorder because they would eat by themselves in their room, or they would say that they ate at X place, but they really didn't eat at X place. And so if you're seeing folks who are sort of engaging in some of that more like secrecy kind of behavior, like if you aren't seeing them, the family system can't remember the last time they saw them eat, that kind of thing. I think that there are some of those elements to keep in mind as well to make sure that you're thoroughly assessing and treating as indicated.
Thank you all. So we do have some time if there are any students or other professionals today watching our panel. If you have any questions for our three panelists, now would be the time. So I'll go ahead and mute my mic and let y'all ask the questions.
I did have one question. So I remember y'all talking a bit about like online space a bit. My audio did cut out. But I've noticed, I guess, like an increase of online communities where there are people who all engage like in eating disorder like behavior, and they seem to encourage each other to do so. Um, they will like do things like get other pictures from other people online and say like this is like the inspiration. This is what I want to avoid. So it's like harmful both ways because they could be insulting and harmful to the people that they're taking pictures from and also to themselves. So I wonder like if y'all were to engage with a client who is engaging in this behavior, like how would y'all go about doing that?
I know Emily had mentioned previously kind of going through maybe together with the client and getting rid of some of those like harmful things, whether they're pictures, whether they're saved websites, And, you know, I think it's just more about education and talking to them about like what they're getting out of it and why they're engaging in something, because, you know, you can't really just be like, hey, stop doing that. You know, a lot of them aren't just gonna stop just because. So it's really about that kind of open communication, and I think discussing like how beneficial is this to you, and what benefit are you getting out of it. You know, eating disorders serve a purpose, right? They, whether it's to cope with loss of control like Christy mentioned, or you know, or body image or whatever. So like all of these actions kind of serve a purpose. So trying to get a little bit more into the therapy realm of like, what is this doing for you? But those sites definitely do exist. And sometimes we try and help rewrite the algorithm of, okay, let's search for more pro recovery stuff. Or if you're not there yet, even like puppies and kittens playing together, like how do we rewrite your algorithm a little bit so that you're less tempted to engage in some of that stuff?
Agreed. Honestly, it's really stinking hard, like because comparison is rampant in eating disorder, like world. It really is, from the websites to the TikTok page, like across the board, even to friends at school and keeping clothes from 8 years ago and trying to fit in that. There's so much comparison that can happen, and it's an integral part of the therapy process is really exploring that comparison and how it impacts them, and when it started, how it manifests. And with that, there's a pretty seamless connection with self-worth, and often that can be lacking for some of our clients who are struggling with eating disorders and are finding themselves comparing and believing that if their body just does blank, then they will be worthy. And so it ends up being a big part of the therapy process that shifts throughout the recovery process too. Because sometimes earlier on, once they might be in like the contemplation stage of change, they might be willing to do something like go through and delete the not so helpful things on their phone and replace them with more helpful ones. But later on, it can be other things like, I'm still finding myself body checking other people's bodies, even though I don't want to. I just have that like innate automatic response now. And so it ends up being part of the therapeutic process in different ways throughout the process too.
I was wondering if y'all saw any correlation or just like experience regarding, people who victims of sexual assault and then eating disorders formulating as a response.
Yeah, all the time. So it's very important to make sure that you're assessing, and yeah, it can show up in a lot of different ways. For example, I'm thinking of a client I worked with who had been sexually abused by a family member for many years and noticed that as she gained weight, then the abuse stopped. And so her body shape and size ended up being a way to keep her safe. And so we see a lot of correlation and relationship between sexual abuse and other forms of trauma with eating disorders. And oftentimes the treatment ends up being this intersected process too of healing the trauma in addition to finding alternative ways to cope and keep oneself safe.
Yeah, Emily, I actually experienced sort of the opposite. I had a client who was assaulted at a quote unquote normal body weight and now has a very big fear of being in a normal size, matured body, and has presented quite a bit of barrier and struggle for them to be able to kind of gain weight in the process.
Yeah, it's just something I've noticed from RTCs who were, and then I work at a like the juvenile justice center, and I'm seeing some tendencies or like focus on nutrition and wellness, but then kind of hitting the ground running as far as taking it a little too far for nutrition and wellness. I think it's a form of control specific for incarcerated individuals as well, not just sexual assault victims. But yeah, I just thought I would ask. Thank you.
Yeah, Kendall, I think we're seeing it across a lot of different types of trauma, right? Not just sexual, but trauma in general.
And I'm this is just going through my head, and I have to wonder if that's because it's a way for them to exert control. When these trauma things happen to you, it's out of your control. A lot of times it's not something you sought out yourself. It just somebody violated you. And so perhaps these eating disorders come about after that because it's a way that they can exert control over have power over their own bodies and situations.
A little bit like piggybacking off of what you just said, I had a question about kind of like, I know that control is like a big thing in eating disorders. So how do you target that? Like, how do you allow the patient to still have some level of control? Because that's going to be like a big factor, because that's kind of what they're trying to like utilize the eating disorder for sometimes. So how do you make sure that they still have like control within their treatment? Because sometimes I know that the treatment's probably like a bit specific just because they have like that physical aspect as well that they have to like follow through. So how do you kind of manage both?
Oh yeah, that's a hard one. So, I mean, a couple of points, right? I think it depends on how compromised the person is, right? Because if there's medical compromisation, right? Like you can't have as much control because we really need to get you stabilized. And that's where the feeding tubes come in, right? And sort of the more forced treatment. I know that sounds really bad, but um and so a lot of times it is about you will lose a lot of control in it, and trying to make it more individualized about how we can sort of give some of that back and have it a little bit more choice. But I think that in the process there will be a lot of feeling out of control, and that's where again I think more of the therapeutic comes in, of the distress tolerance. Like, how can you tolerate now being out of control and out of your comfort zone, and sort of working through that. Um, you know, I recently did a training about, trauma within treatment, and how it's not about no trauma being inflicted, but about how to minimize and reduce harm that you're doing, because it is a traumatic process to go through the refeeding, to go through experiencing your trauma again, to work through the things you need to work through. So it's really just about trying to minimize that the best you can and helping build coping and distress tolerance.
Yeah, it's a great question and an important one. For us at the RTC, we tried to let the clients have choice and autonomy as much as we could where we could, since there were many aspects where they didn't have that choice and autonomy. So things like with snacks, they had to eat 3 meals and 3 snacks a day. However, with snacks, they got to choose what snacks they would eat with the support of their dietitian. So they weren't only choosing the same thing all the time, but there was choice there. Later on, as they progressed through treatment, when they were allowed to do movement again, they got to choose if they wanted to do walk or yoga. That wasn't something that was available for all people, but it was sort of a reward, if you will, as you moved through the process of treatment. And other things too, like in the therapeutic process, we still abide by many of the things that we're taught and trained, like go with the client's pace, build that rapport. The client is autonomous. They get to choose if we talk about that or if we don't, kind of thing. And so there's a lot of ways in which you can empower your client without feeding the eating disorder, if you will, because health and safety are paramount and come first. And also we want to make sure that we're empowering our clients to have the choices and autonomy where they can. And then there's a lot of that therapeutic work that comes a little bit later too, like we're talking about, of being able to tolerate not having control, because none of us do. None of us in the Zoom call have control over all things all the time, that's for sure. And so that can be part of the process, as well as learning how to tolerate not being in control.
Thank you both.
I have a question for more on the counseling side. I know it was mentioned, CBT might not always be, or the cognitive therapies might not always be the best. So what is a theory that you kind of lean on, and what are some maybe specific interventions that you've used that you could tell us about?
I've got lots of them that are coming up here shortly.
Yay.
Yeah, but I will probably overwhelm you with lots of them that we're going to talk about shortly. But I think that you can pull from other evidence-based counseling approaches and just use them as it makes sense with the client's current cognitive abilities. So it could be things like mindfulness strategies. It could be things like doing sand tray, things that the client is currently able to do. If you sit with a client who is malnourished and try to do cognitive therapy with it, their brain just can't. I've sat with a client who was actually only 11 years old in a session, and I remember it was early on when I was working with them, and I still didn't know what I was doing. um, and they kept saying the same kind of stuck thought over and over, and get stuck in a loop of like fear of getting fat, fear of getting fat. It was something along that, repeated for a whole 50-minute session. It's just not helpful. And so trying to figure out ways to still connect with that client and build rapport, but ultimately food first. And when you're working with clients who are in that space of, we're seeing their labs be off and so on, that's really what the therapy was, which is different than how we conceptualize therapy when you're in school oftentimes. But it's really about like, how do I support this kid to get them nourished? And sometimes that would be, I built rapport with the kid, they felt comfortable with me, and so I was eating a bunch of meals and snacks with them, and we were just talking about life while we were eating. And I was supporting them and encouraging them to, keep taking bites, tell me about their dog. And so there's different ways of conceptualizing therapy in this context that look different than other presenting concerns outside of eating disorders too.
Thank you.
For the clients that y'all have worked with, I'm curious as to how many of them, like, you ended up seeing again later on in their life. Was that like a kind of often, or was it not so often? And was it like quick, like the next year or something, or was it sometimes even like 5, 10 years down the road?
It really varies. We like to talk about how recovery and treatment are not linear, right? It's not a straight line to quote unquote sick to recovered. Um, there are some people who, are in a good space and something happens and they need support again, or maybe they weren't in the space that they thought they were or said they were, when they left and came back. So I have definitely seen clients come back to a higher level of care. I don't think it's super uncommon. And I really do think it's sort of about like just their place in life and recovery and what they were able to at that time to put into it, right? Sometimes you're not able to get past a certain hump, and that's okay. It doesn't have to always be 100%. You do what you can, and you try and go from there. But yeah, I would say that we see people come back, and I would say it's in a shorter time period, especially for teens, maybe less so with adults. Um, yeah.
Agreed with everything that Lauren said. It wasn't uncommon for us to see folks again. It normally was more like shorter windows, like 2-3 months later, a teen coming back to treatment. And it was hard on the treatment team sometimes. Sometimes they would have like self-talk, like, oh my gosh, did we not do enough for this kid? What happened? And so we would often lean on each other and support each other through some of those things if they came up. But recovery is definitely not linear. And eating disorders are layered. There's a lot to them, and there's a lot of healing that needs to be done in order for someone to be recovered. And especially when you're working with adolescents, if you think about other mental health diagnoses too, it's not normally a wow, magic cured 1 month later. It is a layered process. And so we also try to instill that in the families that we're working with as well, that if you do come back, that's not meaning that you're a failure. It's that life is hard and everything that you've been through has impacted you, and you're still figuring out how to maneuver through that and how to cope through it. And so we also try to like make sure that the treatment team's not beating up on themselves for that and feeling like a failure, and then also the client or the families not feeling like they failed if they do need additional support on the back end.
Thank you. That was
I was wondering how prevalent the conversation of ortho versus anorexia or bulimia has become, or at least like diagnoses.
So there's anorexia nervosa restricting type, there's anorexia nervosa binge purge type, and then there's also bulimia. So in terms of bulimia versus maybe the binge purge type, I would say that I see binge purge anorexia type a little bit more frequently because of the it's a little bit more stringent on the criteria for bulimia, I would say. But there are a lot of people who come in with some type of purge behavior, right, or compensatory behavior, whether that's laxative misuse or exercise or purposeful vomiting. So there are a lot of different people who typically have sort of like a coexisting on top of the restriction.
Okay, yeah, I was just exploring orthorexia recently. So I just wanted to know, I guess because I haven't really heard much conversation about it. I think most of the focus surrounding eating disorder is anorexia and bulimia nervosa. So yeah, I just thought I would ask.
Yeah, so orthorexia isn't technically a diagnosable, right? It's not in the DSM-5 quite yet, Emily, I don't think. But I do think there are talks about it being included in at some point. And that's a little bit harder to diagnose because I feel like that falls a little bit more under the category of disordered eating versus eating disorder. I think a lot of family members, friends, whatever, have participated or practiced in some kind of orthorexic tendencies without having a full-blown eating disorder. So I think you'll find that's super prevalent, but not necessarily at this time like a really diagnosable, thing.
And then there's lots of larger problems we can talk about too, like insurance reimbursement. Good luck getting an insurance company to reimburse for something like orthorexia compared to something like anorexia nervosa restricting type. And so there are other systemic factors that come into play as well. Like even though we know binge eating disorder is far more pervasive in the United States than anorexia nervosa, we see anorexia being treated more. Why? Because there's a lot of systemic biases, and there's fat phobic tendencies and sizes tendencies. So there's a lot of systemic factors that trickle down and impact what we see and treatment and diagnoses and who can receive treatment and why. So that also might be something to consider and might make more sense as you're connecting the dots there too, since most people do need insurance, especially for something like residential treatment, which is many, many, many $1,000s a month that most people can't afford without insurance support.
Yeah, thank you for that. The insurance piece was something I hadn't considered as far as diagnoses.
Thank you all. Thank y'all for your questions, and thank you to our panelists who were able to join us today and give your insight. I'm just kind of cutting things off here just because it has been an hour since we started, and I want to respect Dr. Horton's time for the training, as well as give y'all a little bit of a break. So, virtual round of applause for our panelists. Thank you so much for joining us. I will be in contact with y'all for like the paperwork and stuff. But yeah, thank you. And Dr. I don't know like how long the break you want it to be or anything like that.
Yes, well, I want to say outstanding job to all our panelists. We really appreciate your experience. Thank you for sharing so much of this information with us. It's been very, very helpful. So we really appreciate it. And everyone's welcome, of course, to stick around. We are going to have next our training. And I'd say a 15-minute break is probably a good amount of time. So we'll all come back probably like around like 10:22. So 15 minutes.
Awesome. Well, thank you all so much. I hope you all enjoy the rest of your training.
Thank you.
Thank you.
Thank you.
Thank you. I'll see you here shortly.
Yes. How do we pause the video? Okay.
Back, everybody. All right, welcome back. We're going to go ahead and we're going to get started with the presentation. But before we do, I just want to say, if you can, please have your cameras on. But I understand that there might be some people who already had approval not to because of extenuating circumstances. If you've already had approval by your supervisor to have your camera off, that's totally fine. But to the rest of you, if you could please have your camera on, just so that we know that you're, attentive, and that the presenter knows that you're attentive so that they can engage with you. Of course, you're welcome to turn it off for a few minutes if you need to, but otherwise, please try to have it on. And so we can go ahead and get started, unless Bethany and Sharon, if y'all had anything else y'all wanted to share. Okay. All right, Dr. Horton, it's all yours.
Thank you. Could y'all make it so I can share my screen, please? Thank you. Also, while we're getting that set up, are we able to do breakout rooms here shortly? Is that an option for y'all? Okay.
I can make you a co-host so that you can start like doing those things.
Oh, thank you. That would be super helpful. There we go. Marvelous. Okay. Well, hello, everybody. I hope that you had a few minutes to stretch and nourish your body, take care of your needs. I am really looking forward to chatting with you with the rest of our time today about all things eating disorders. I love talking about this topic. When I finished my PhD, I got a job offer to run an eating disorder clinic, and I was so excited because it's almost like a dream job after you just finish a PhD to be invited to run an eating disorder clinic. And then I was like, oh crap, I don't know anything about eating disorders though. And so I had to learn, and ever since I've been really passionate about helping other counselors learn about eating disorders so you're not thrown in the deep end. I don't know about y'all. It seems like you're getting training and exposure, which is really nice, but it's certainly something that was lacking in my experience, which makes me really passionate about talking about it with others. And with that, I really invite you to be open and like to sharing and asking questions. I love dialoguing, and there are no bad questions. This can be a difficult topic to talk about for a number of reasons, including a lot of misconceptions and biases and so on. So I hope that this can be a space where we can openly share and dialogue together, because that's a really big, important part of the work. With that, I'm gonna put a PDF of the slides that I've got in the chat for you all. I am someone who over prepares, so I don't know that we'll make it through everything, but we've got extra resources in there for you as well. Okay. Without further ado, then we can go ahead and dive in and chat some more about eating disorders. There we go. Good. And quickly, before we dive in, I wanted to do a quick check-in with you all. Let me stop sharing, actually. If you were thinking of and checking in with yourself this morning, on a scale of 1 to 5, 5 is I think I'm an expert in eating disorders and I could write a book on it. And 1 is I know very little and it kind of scares me to think about someone walking through the door and me having a client who has an eating disorder. Where would you rate yourself in terms of your current comfortability? You can throw a number in the chat. You can show me with your fingers on camera. Yeah, thank you all. Thank you. I appreciate y'all being willing to start off in a pretty vulnerable way, because it's not exactly comfortable sometimes to be like, I don't totally get this and it kind of scares me. And I fully recognize that eating disorders can feel very scary and intimidating as you're learning more about them. And so I am grateful that you're sharing openly about I see a lot of 1s, 2s, 3s. So we're in this process of learning and figuring it out together. And I hope that as we move through our time today, that we can nudge you just a little bit. And even if we can get to like a 1.25, beautiful. One of my big goals is to help you all see that eating disorders aren't as scary as they seem. They need to be taken seriously, of course. However, I hope that as we maneuver through the process today, we can walk away feeling a little bit more at ease with, okay, I have a little bit of an idea of what I would do if someone walked in with an eating disorder. Okay, here we go. Briefly wanted to touch upon some overviews of eating disorders with you all. We were talking about it some in our panel, which is really lovely, but I wanted to make sure that we're all on the same page about some basic facts about eating disorders, because there's a lot of misconceptions about eating disorders. One of the primary misconceptions is what eating disorders look like, as we were beginning to discuss in our panel this morning. But it's really important that you all as clinicians recognize that eating disorders show up across all kinds of different identities, all ethnicities, genders, sexual orientations, abilities, ages. There can definitely be misconceptions that eating disorders include only anorexia nervosa restricting type and only happen to 16-year-old white females from affluent backgrounds. Like that's oftentimes the bias and the stereotype that people visualize when they think about eating disorders, but the data consistently shows that that is not the case. And so I've got some information to share with you all to help you have a more realistic understanding of eating disorders so that you're considering that in your practice. Some of the things that are important to recognize are that there are also misconceptions that eating disorders only show up for folks in puberty and that adolescent age range. And while there certainly are a number of people who do experience eating disorders around the time of puberty, we know that eating disorders can show up for people as young as 7, according to that resource. But I do research in the area of eating disorders, and we're actually seeing people suggest earlier and earlier. We're seeing kids as young as 3 having body image dissatisfaction and urges to diet to change their body shape and size. And also people all the way up until their 80s and beyond have been diagnosed with eating disorders. And so it's certainly not just adolescents who experience eating disorders. And I wanted to provide some other stats for you all to consider too. Some of the important ones are that anorexia nervosa is the most diagnosed and treated eating disorder, but the one that is actually most pervasive in the United States is binge eating disorder. And it's also important for you all to recognize that eating disorders do have some of the highest mortality rates across any mental health diagnoses. Depending on who you ask, some people say it's the most deadly mental health disorder, and others say it's the second most lethal mental health disorder, second to substance use disorders and overdoses. And this is normally what scares people with eating disorders, is hearing that there are people who die as a result of an eating disorder. And that can be really scary and intimidating to think about as a clinician, but the stakes are high because there can be medical complications like cardiac arrest or a number of other medical complications, or malnourishment for a sustained duration of time, or attempting and completing suicide. And the numbers really are quite scary when you're just looking at them on paper. But as you dig a little bit deeper into them, you realize that there are many other factors at play here too, including folks who didn't get treatment ever, or including folks who were able to go to treatment once, but they needed to go back and they couldn't afford it, etc. And so there are many other factors that are at play when it comes to eating disorders. And what I hope you all are taking away from some of this information is that eating disorders need to be taken seriously. It's really important that we're assessing and treating eating disorders because they can have critical impact on someone's physical and mental health. When you look at the numbers of folks who receive treatment, though, they're far less scary. There's a lot of other factors at play there too. And I want to help you all with breaking down some other myths and assumptions. Again, just really hitting home that stereotypical client that most people think of when you imagine an eating disorder being like that white, young, upper class, small-bodied, able-bodied, heterosexual, cis female is not congruent with the stats, since we know that it affects people from all races, all body shapes and sizes, all abilities, ages, genders, socioeconomic statuses, etc. And some other stats I wanted to share with you all, that there is a higher prevalence of binging among Latino men, in fact, 10 times higher than some other groups. We see that 93% of trans youth report body dissatisfaction, and those high comorbidities with disordered eating and eating disorders for our queer and trans youth. That 2.45 times for higher weight adults reporting different disordered eating behaviors. So takeaways that I hope you all are absorbing from some of this information as we're chatting this morning is that disordered eating and body image issues do not discriminate. And so I hope that you keep that in mind when you're thinking about your caseloads and assessing, to make sure that in your intake procedures, you ask people from all walks of life about their eating habits, about their relationship with food, their relationship with their body, their relationship with exercise or movement. And also another takeaway, that minoritized groups tend to be at higher risk based on the stats that we have available to us: BIPOC clients, queer and trans youth, people in larger bodies, etc. And what I was hoping that we could do next, do y'all have a pen and paper near you that you could grab? Or if you have art supplies around that are pretty accessible, you might grab those. Or if you're on your computer and you can open up like a paint tab. Essentially, we're going to be drawing here just a little bit, if y'all are open to it. Okay. I'm seeing paper movement. That's good. All right. I'll give y'all a few seconds here to grab some supplies. We're going to be drawing a flower or a tree. So anything in your vicinity that you can easily grab that might be helpful for drawing a flower or a tree. If you've got markers or a pen or whatever you've got available for you works. Oh, thank you. I see the thumbs up. Okay. All right. And one of the critical pieces for eating disorder treatment as a clinician for you to consider are your own biases, your background, how you grew up with food, bodies, movement, what were the shoulds that you were told, that you internalized. It's incredibly important for you to openly, honestly reflect on your relationship with food, bodies, and exercise. As the clinical director, I hired folks who had never worked in eating disorders, just like I had never worked in eating disorders prior. And this was a critical part of our training process, is if you're going to work with people from this background who have these different diagnoses, you need to be incredibly aware of your biases because they come up. Just like your biases come up in regards to many other different areas like racism and sexism and so on. Everyone has different relationships with food, bodies, and exercise, and they do come into the therapy space. I'm thinking about counselors that I've supervised who have, for example, internalized the message that thin is better, which is a message that many people internalize. And in turn, their client walks in and they see that their client lost weight. And then they say something like, "Oh my gosh, you look so good. I can tell you've lost weight," without stopping and thinking about eating disorders. And maybe that client has actually been restricting food or purging food and has been struggling with an eating disorder. And that's why their body is shifted. But if the counselor has that internalized message of a thin body is a better body, then it can come up in terms of what they say to their client. So what I'm hoping that we can do here next is to do a little bit of exploring about your relationship with food and body and exercise. So I'm hoping that most of y'all were able to grab something to draw with, okay? And what I would invite you to do is to, if you want to close your eyes, you can. Or you might just start scribbling down ideas, whatever works best for you. But I'd like to invite you to start to think about the messages, both positive and negative, that you were given about your body. What were you told as a young person about what your body should look like or what it shouldn't look like? From your family, from your friends, from your community, from media like TV or magazines, from your religious institution, if it applies to you, from your culture. What were you taught about your body and what it should look like when you were young, or maybe even more recently? And also start to think about, what were you told about food and eating and exercise? What should you do? What should you not do? And what does it mean if you do those things or if you don't do those things? And what messages did you receive about the size and shape of your body or other people's bodies? What should a woman's body look like? What should a man's body look like, as examples? And think about, where did you learn what was acceptable or unacceptable regarding your body, regarding food, regarding exercise? And when you're ready, you might start to draw any kind of plant that has roots. So it might be a flower, it might be a tree, could be a cactus, can be whatever you're feeling connected to, but some kind of plant that has roots. And I invite you to write as many of those roots as you can think of regarding food, body, and exercise, and write those in for your roots. And I'll give you some time to work on that. And afterwards, if y'all are open to it, I was going to see if we could go and break out rooms and share what we feel comfortable sharing with each other. But go ahead and spend some time thinking about, reflecting on, identifying some of your roots with food, body, and exercise. And if you have any questions or need me to clarify anything, please let me know. And you might think about any other intersectionalities of your identity. If you identify as a gay man, what does the gay community say about what bodies should look like? Or if you are someone who has birthed a child, what has been told to you about what your body should look like after birthing a child? You might think about any other parts of your identity and what messages you've been told from those places too. If y'all could give me thumbs up or let me know when you feel like you've gotten what you need to on paper, that would be helpful. Okay, I see a couple of thumbs. Thank you. Okay. Thank you, thank you. So go ahead and see if you can get to a stopping point here in the next 30 seconds or so. And what I will do is open breakout rooms for y'all to discuss what you feel comfortable. Again, you don't have to share all aspects. You can just share what you feel comfortable sharing with the other people in your group, but you might discuss what was coming up for you, what some of your roots were. You might discuss what that process of reflecting on that was like for you. And you might start connecting the dots with your identity as a clinician. And knowing that these are some of my roots, how might it show up and impact me in a room with a client? Okay. And, okay, so I'm gonna open the breakout rooms and y'all will be in there for 5 to 7 minutes and go ahead and talk about your roots and what it was like for you.
Okay, I'll join in the room. See what students are up to. Brittany, Melissa, if you could please join the breakout rooms. Okay.
Okay.
All right. I'm gonna go ahead and head in the breakout room.
Yeah, I was gonna bounce right and check too. I wanted to ask you, when is our next like pause point, or how do breaks and stuff work for the day?
It's up to you. That your time is from 10 to 1, and then you can do however you want to do it during those 3 hours. And then after that we have a video that we show them for the last hour. You can stay for that too. But yeah, however you want to break it down in terms of breaks and stuff. Yeah.
Okay, cool. So do we do a lunch break or just like shorter breaks kind of
No.
thing?
We usually don't do lunch breaks.
Oh.
They usually eat during the training if they need to, but usually they don't need to.
Okay, cool. Just wanted to make sure I was going with y'all's normal flow. Sounds
Yeah,
good.
it's usually just the break between the panel, the training, and then the training, and then we give them a break before we do the video at the end.
Okay, perfect. Sounds good. Thank you. Okay, yes, let's go spy on them, see how it's going.
Yeah, so as far as you know, it being disrespectful.
Give folks some time to join. It says 27 seconds. How often do y'all get to do these trainings as part of the Tex-CHIP program?
We have 3 every semester, so we'll host about 9 per year. So
That's awesome.
a month, yeah.
Okay. Looks like folks are rejoining. I think we've got everybody back. Okay, welcome back. Welcome back. Thank you again for being vulnerable. I realize it's a big ask on a Saturday morning, but I really appreciate you being willing to dive a little bit into some of your experiences. If anyone is open to it, I wanted to open the floor for some large group discussion. I was curious about what might have been coming up theme-wise in your groups, or takeaways or questions that might be good to share with the large group.
So in our breakout room, we specifically talked about systemic barriers to nutrition for certain populations. So that was really cool to unpack together.
Absolutely. Yeah. Do you mind me asking for an example of one that y'all were exploring together?
Yeah, so specific to Latinx and Hispanic cultures, and like the traditional food, cultural ties to foods that Hispanic and Latinx cultures experience versus, someone being like a Black or Orient, ethnicity, race, and how like while we eat different things, they mean different things within our cultures and even mean similar things to one another in our cultures. But then ultimately that both minorities experience those systemic barriers for cost. Like can't really afford healthier food options or more nutritious food options.
Yeah, absolutely. Thank you. I appreciate you sharing that, because the systemic factors are critical to consider when you're working with clients, and the cultural factors at play and what it means, and the systemic factors and how that impacts things like food security, and being really mindful and aware of those, and then making sure that you're exploring them adequately with your clients is a big part of the work too. Thank you. What about other groups?
The group that we had, we went into some culture stuff, but I thought it was interesting that we brought up things in school. So like we recall like posters like that would have like the plate with the nutrition stuff on it. I recalled, and it was like an unlocked memory for me, in the nurse's office at my elementary school. There was two posters. One was like a fairly thin young boy who was like smiling. He was happy. He was like, look, this guy's healthy, and this is how he feels. And then next to him was like a larger little boy who was like, he looked sad, and it was like, he's unhealthy. Look at these things that he feels. And I just think about that, like how much I would just look at that in the elementary school nurse's office all the time. But that it, I'm not too sure now. I did work in schools a lot, and I hardly ever saw posters like that. But it, in like the early 2000s, just how prominent things like that were at the time. So
Yeah, I appreciate you sharing that. You're right. It's pervasive everywhere. It feels like, especially once you start to get more aware and start looking, you notice it more and more and more in schools, or even in media. Villains are often people in larger bodies. Like why is Ursula, like if you start to really pay attention and critically think through it, you can see a lot of the fat phobia and sizist mentality in lots of places, from schools to posters to Disney films. And it definitely impacts young people. Thank you for sharing. Yeah. Any other themes?
In our group, we talked a little bit about one of the common themes was just body image. And we talked a little bit about the Hispanic culture and growing up within a Hispanic household, being told to eat all of the food on your plate before leaving the table, but also being called out when you are gaining weight. So just the contradictory that happens within the home. You want me to finish everything on my plate, but also telling me when I'm gaining weight. So it was really difficult navigating through that. So that's a little bit about what we talked about.
Yeah, thank you. I appreciate that. And like having done this work, that's something I've heard before too, like that it feels like a lose-lose no matter what I do when it comes to food and bodies. And like I've heard some people share about their experience with nicknames too, like being called gordita as their nickname, and like some of the impact that some of those things can have on top of this lose-lose if I have to eat it all to show respect. And also I'm going to receive comments about my body. Yeah, thank you. I'm curious if anyone is drawing any connections between these roots that we're exploring and how it might impact you as a client sitting with, as a counselor, sitting with clients from different backgrounds and body shapes and sizes who might have an eating disorder or disordered eating.
I think it can definitely, like, if you have that experience or the experience, I guess it definitely helps you understand the client on a more deeper level. Because it it really gives into perspective, like I totally get where you're coming from, because I see it and I've experienced it too. Which can also help the therapeutic relationship. Um and that goes like for a lot of other things too, but in this particular area, recognizing that like things like fat phobia or like the reversal of it would like exist,
Mhm.
can definitely like increase the rapport that you're trying to build.
Yeah,
So.
absolutely. Yeah, thank you. And that's why I love this intervention. I've used it with clients and groups and individuals, and it can be really impactful in exploring some of that. And then also in more like supervision context for clinicians to really understand where they're coming from and how that might show up and impact the therapeutic alliance. Yeah. Any other thoughts about how some of these routes might impact you before we switch gears?
I personally really liked the activity. I thought it was very insightful and it put a really nice image as far as like what can be deeply rooted in someone's like cognitive processing. So kind of acknowledging those things, and then also like I think that could be important for treatment planning, because if it is like cultural stuff, then you have to keep that in mind, that those kind of situations are going to continue to happen just because it's somebody's culture. So kind of knowing a way to address that in a way that's like culturally appropriate, I think is really helpful for kind of building that flower, because you don't want to like, for example, like if I was to tell my grandma like, I don't want to eat like your food because I'm trying to watch my weight or my health or something like that, she would be really offended. So kind of being able to address those things too, like in therapy, because I know I would have a hard time kind of navigating how to tell my grandma no.
Yeah, exactly. And I appreciate that you're right. That is part of the treatment planning and the treatment process, is to explore those things, identify them. And eating disorder treatment, we talk about like being able to identify your hunger cues, when you're hungry, when you're not hungry, when you're sort of hungry, and trying to honor them and to help a client figure out, well, how am I going to navigate what we've been working on in therapy to try to notice and honor when I'm hungry amidst some of these cultural factors, like when I go spend time with my family for a holiday. Yeah. I think someone else was going to speak, but I missed who it was. Maybe not. Okay. Awesome. And if there aren't any other final thoughts, I also wanted to share with you all again just how important it is for you to do your own work when it comes to your relationship with your body and food and exercise, because it absolutely will impact how you work with your clients. Even if you're not an eating disorder specialist working in an eating disorder facility, it will impact how you show up for clients. I think about, like, to this day, I had a client a number of years ago before I started working in eating disorders and knowing more about it, who had experienced many years of trauma, and there was sexual abuse, and she's struggling with her job as a teacher, and lots of stress and burnout there. And one of the experiences for that client was a binge eating disorder. And I remember feeling so unsure of what to do to help with the binge eating disorder, so I just didn't address it. I was like, I can help you with your anxiety. I can help you with the trauma. I know how to do that. I was trained how to do that, but I don't know what to do with the eating disorders. And even just like thinking about how some of my biases showed up there, I was taught that like a woman must be in a like thinner, or no one's going to want to be in a relationship with you, kind of thing. And thinking about how that was a message that was stored in my body that impacted my work with that client. And I wish I could go back and do it over. I would do so much of a better job this time. And I don't even think the client like thinks that it was bad, but I think about it to this day, that I wish I could go back and redo it in a more responsive way. But just, I hope what you're taking away is like my story, my experiences do impact how I'm able to show up for clients, and it's really important for the eating disorder work. Also, as an extension of this, if you were finding yourself connecting to this particular intervention, after the roots, you can move up to the trunk of the tree or the stem of the flower and have them explore sort of their relationship with body, exercise, movement, food now. And so with this, the trunk or stem is sort of their messages now, and then moving up to the top of the tree or the flowers, where you might explore with them where they'd like it to be. Like, what do you want your relationship with body, food, exercise to be? If you were curious about that. Okay, so we can jump back in here. And wanted to chat more with you all about eating disorder classification. There's different types of eating disorders. If you break out your DSM, you can see more about them. The most common ones that we see diagnosed are anorexia nervosa, bulimia nervosa, binge eating disorder, but there's also ARFID, avoidant restrictive food intake disorder. We'll talk a little bit more about it, but there's also a different umbrella here of other specified and unspecified eating disorders. And so you see them called OSFED, OSFED, other specified feeding and eating disorders that could apply to different clients that you're working with. And so anorexia nervosa is the one that comes to most people's minds. And I think that we could really dive in and explore a lot of the systemic factors at play. I mean, we mentioned a little bit of them. I think one of the reasons that we see anorexia as one of the eating disorders that is most recognized and most assessed and most treated is because of a lot of greater systemic biases, since there is that fat phobia and sizeism that's really rampant in the United States and beyond sometimes, that there can be biases in terms of wanting to help and heal the folks who are in smaller bodies compared to larger bodies. And there's definitely some systemic elements that you might keep in mind too. So anorexia nervosa is certainly an eating disorder that we see and that we work with a lot, though not the only one. And anorexia nervosa really does have that focus on that intense drive for thinness, and in turn, some kind of restriction as a result of that drive for thinness. So it's not just I would prefer if my body looked different, but it is a deep rooted in your core level of fear of your body being fat or gaining weight. And it can be very hard for people to wrap their brain around if they haven't seen it or experienced it. But some of the features that you normally see for anorexia nervosa are the refusal to maintain a normal body weight, that intense fear of gaining weight, and a really significant disturbance with the perception of the shape or size of their body. And the perception is a key word there, because oftentimes people who are struggling with anorexia nervosa might feel as though their body looks drastically different than it actually looks. And even if you say things like, but you're not, what you're fearful of being, that's not helpful, because there really is this deep rooted perception of the body. And there's different subtypes. We talked a little bit about that during our panel this morning too. So there's the restricting subtype, and that's the one that comes to mind for a lot of people. The weight loss that is accomplished through dieting, fasting, or excessive exercise. Or if you're looking at diagnoses, you can also have the binge purge subtype, which we talked about in our panel this morning too, where they might regularly engage in binge eating or purging, or both, during an episode. And the purging can take a lot of different forms. Could be the self-induced vomiting, could be using laxatives. It could even be exercising for compensation. So for example, there was a client that I worked with who would do sit-ups every day in secrecy, but would do, like, we're talking 800 sit-ups a day, to the point where they had bruises all up and down their spine, on their back. So it can take different forms too. And then there's bulimia nervosa, which it has the compensatory methods to prevent weight gain, and it can show up in different ways too. And this is still focused on influencing the body shape or size. So the self-induced vomiting or laxative use or exercising for compensation to try to shift what the body shape and size looks like. And there's more specific criteria for bulimia nervosa than the binge and purge type of anorexia, which you've heard come up in our panel discussion some too. So that's why sometimes you could see someone be diagnosed with anorexia nervosa, binge and purge type compared to bulimia nervosa. That there has to be a discrete period, any 2-hour period in which an amount of food is eaten that is larger than what most people would eat in that same period. And then that the client experiences a lack of control over the eating during the episode is the first criteria. And the second criteria being some kind of behavior for compensation that can be any of those that we named, like the vomiting, laxatives, diuretics, or other medications, fasting, or excessive exercise. And then there's binge eating disorder. Again, this is the one that statistically is the most present in our society in the United States. However, is the least assessed, least diagnosed, and least treated. In fact, when we had adolescents at the residential treatment center who were present for binge eating disorder, we had to fight hard to get insurance to cover their treatment for more than just a few days because they didn't understand, and there was definitely a lot of biases about binge eating disorder and believing that it was somehow less severe or to be taken less seriously than other eating disorders. So you can definitely feel the biases present there that impact treatment and coverage by insurance companies too. But binge eating disorder involves recurrent episodes of binge eating, and an episode of binge eating, to be clear, is eating in a specific window of time and amount of food that is definitely larger than most people would eat in a similar period of time under similar circumstances. And there's also that lack of control of eating and overeating during that period. What is really important for you to know is just like people throw out things like, I'm so OCD, I'm so ADHD, and they're actually not, in this very like unserious way. People throw out the word binge eating in that way too. So sometimes you'll hear clients say something like they had a binge or they binge ate, and you really start diving deeper and asking more questions, and you realize it wasn't a binge at all because it was more like an amount of food that someone would typically eat. So what you can sometimes hear is, say if you have a client who has some of those deep roots about food, they might think that it was a binge, but you ask more questions about, well, tell me about that. Like, how much did you eat? What types of, like, did you understand more about what they ate and what window of time? And it really wasn't. Maybe they ate like 2 apples. And you're like, oh, in your head, you know, like that doesn't meet criteria for a binge. And also, if you're working with a client who has a different eating disorder, like anorexia nervosa, sometimes they will tell you that they binge, but they really had a normal meal for other people. And so I encourage you, when you hear that language thrown out, to really assess what that means, to make a call for yourself of if it meets criteria as indicated in the DSM for binge eating or not. And the binge eating episodes are also associated with 3 or more of the following, like eating much more rapidly than normal, eating until they feel uncomfortably full, eating large amounts of food when they don't feel hungry, eating alone because they're feeling embarrassed about how much they're eating, feeling disgusted with oneself, depressed, or very guilty afterwards. And this also occurs on average at least once a week for 3 months. And so there's pretty specific criteria for it to be binge eating disorder. And then there's that other specified feeding eating disorder that we see. It's considered a little bit of a catch-all classification, but because essentially the other eating disorders that are still serious can fall in this space if they don't perfectly fit in some of the other options. So orthorexia being one of them. Orthorexia is that obsession with all things healthy, like healthy foods and exercising and so on. And so since that doesn't always perfectly fall under the criteria for some of the other eating disorders, it could be diagnosed as OSFED, other specified feeding and eating disorders. The problem that can show up sometimes is that there's this misunderstanding that an OSFED diagnosis is somehow less serious than anorexia, bulimia, or binge eating disorder, even though that's not true. It can still be an incredibly serious, life-threatening, but also treatable eating disorder. And so we've seen that clients who score for like OSFED and can be diagnosed with that, score just as high on measures of eating disorder thoughts and behaviors as some of the other DSM diagnosed eating disorders, and that it needs to provide some kind of distress in order for it to meet the criteria for this diagnosis, but for it to not perfectly fall under the umbrella of others, but it's still serious. And so if you're thinking about advocacy, sometimes I would be on the phone fighting insurance companies and explaining to them that they didn't understand, and that atypical anorexia is just as serious as anorexia. It's just atypical. In terms of the DSM was written by, white, educated, industrialized, rich, democratic nations, and it doesn't perfectly capture the experiences of clients from other backgrounds. And so making sure that you're cognizant of some of these things and doing advocacy work as appropriate, because a big part of my role really was doing utilization reviews with insurance companies and fighting them and educating them about eating disorder diagnoses because they didn't always understand. Okay. If y'all have questions or comments, please feel free to let me know.
I do have a comment real quick.
Yeah.
When you were bringing up like the socially how people will say like that they were binge eating or things like that, I noticed that happens too in terms of like health, like other health instances, like with diabetes. I see a lot of people who will like get something really sugary or something, and they'll say like that's like a diabetic coma or something like that. And I try to catch those instances too, because diabetes is also very misunderstood and also connects a lot with body shaming and things like that. And that usually happens a lot with people policing others' bodies online, where they see someone who's like not what they think is the ideal body type, and they'll instantly question their health and like things like that. So just wanted to point that out.
Yeah, I'm glad that you did, because you're right. There's so much there. Language matters. I mean, we know that as counselors, that language matters a lot, and really trying to understand what people mean by things and not misusing terms, because that can be really hurtful to folks who are struggling with or impacted by those terms sometimes. And diabetes is one of them. And one of the things that I was thinking about too that's really disheartening when it comes to eating disorders and diabetes too, is that many of the treatment facilities that I know of would not take a client who had an eating disorder if they also had diabetes. I saw the look on your face, Auntie. You're like, what? Yeah, I know. And so there's so much there. They would say things like it's too high of a risk and blah, blah, blah. But there is so many barriers and misunderstanding that has great impact on the clients that we serve. I remember calling like more than a dozen facilities trying to find someone who would help a kid who had type 1 diabetes and an eating disorder. Yeah, so there's a lot there. Yeah. Thank you. I get excited and I get going, but yeah, please let me know what questions or comments y'all have. I love talking it through with y'all. Yeah, not even thought of it like that. Yeah. Okay. And I also wanted to talk with you all about the biopsychosocial model. Have y'all learned much about it before? Nods. Okay, good. So just like you've learned about before, how there's biological, psychological, and social impacts for our clients, there is very much so a biopsychosocial impact for eating disorders for you to be aware of and to consider. So when you think about the biological piece for eating disorders, it often looks like a genetic predisposition. So most of the clients that we saw also had a family member who had an eating disorder. It might have been a mom, an uncle, a sibling. It was not uncommon at all for there to be other people in the family who also had eating disorders, whether they be diagnosed or not. So that's one piece for you to consider. There's also a psychological element that is really important for us to be mindful of too. Some of the there's always some kind of thing as like a salient experience or transition that is normally going on for a client when they're struggling with an eating disorder. So for example, I'm going to make up a number. I have no actual proof to back this up, like stat-wise, which I don't love doing as a researcher, but here we go. I would say like a staggering number, if I were trying to do a best estimate here, like maybe 70% of the teens that we saw at the RTC had parents who were actively going through divorce. And I'm just using that as an example for it. So the psychological experience, including large periods of transition, is another element for you to consider when it comes to eating disorders. There's frequently some kind of change. It could be puberty. It could be family going through a divorce. It could be being sexually assaulted, but there's normally some kind of experience psychologically that goes on and impacts the client in terms of the psychological element. And then there's the social climate, like societal influences and expectations. And that could be from social media to experiences at school. I remember working with a client who they were struggling to make friends at school, and there was a comment made to them essentially by another peer that they would be pretty if they lost weight. And so then they started restricting food and exercising for compensation, and their body shape and size changed, and then they were allowed to hang out with that other group. And so there can often be a social element too. There can even be social elements that come up from the family dynamics as well. I've worked with families, for example, where the caregivers made the children participate in like really stringent exercise routines, like making them do 5Ks and run as a family activity. And I'm not saying that that's always inherently bad, but sometimes like really taking it to an extreme and such that it ended up being a social factor that played into this biopsychosocial factor. And sometimes it's like a perfect storm of various factors that can show up and impact if an eating disorder manifests or not. But we know that eating disorders are biological illnesses that intensify vulnerabilities to developmental, interpersonal, and environmental factors, including the idealization of thinness. Or sometimes the idealization of muscularity. There's some gender dynamics that can sometimes be at play, but of course they're very muddy depending on a client. It can look very different for a non-binary client or queer client or trans client or someone who identifies as male or female, but there are gendered expectations about what a body should look like. Sometimes it can be that drive for thinness for female identifying bodies, and it can be a drive for muscularity for male identifying bodies. But essentially, one way that you conceptualize eating disorders is sort of like a gun analogy is what the literature suggests, that essentially that genetics loads the gun and the environment pulls the trigger, so that if genetically predisposed to an eating disorder, then something happens in their environment, like bullying or trauma or divorce, etc., then the environmental factors can, for the metaphor, pull the trigger, and then an eating disorder can manifest. Was someone going to say something? And I also wanted to share with you just how complicated eating disorders are. And I think it's important that you all recognize that In terms of the eating disorder world, we believe that full recovery can happen. It can take a long time, but it's different than the substance use addiction world. So oftentimes in like substance use addiction worlds, you hear things like you're always an addict and you're in recovery. And one of the things that makes eating disorders different is that we do believe that people can be recovered, not in recovery, always struggling with eating, but you can be recovered. And that is very much so possible. That's one of the distinctions too between eating disorders and addictions. It's oftentimes people are like, okay, Emily, is it basically like a substance use disorder? I'm like, there's definitely some parallels, but there's also some differences. One of them being that you can be recovered from the eating disorder perspective. And also, you can avoid food. Like you can cold turkey a substance, but you can't cold turkey food. So it ends up being a bit different in some respects too. But essentially, some of the complexities that I wanted to highlight with you all include that full recovery is very possible. It can take a long time sometimes, but you also can expect quick changes in terms of like food. Maybe they're eating another meal a day than they were before. And in terms of the emotional stability, and maybe they were self-harming via cutting themselves. And now they are no longer doing so now that they have more support. So you see the changes more quickly than you might imagine. And just like we were talking about in our panel, recovery is not linear at all. A lot of our clients will need to move up and down in terms of the level of care many times, several times. They might have to be in residential treatment more than once. And we were talking some about that this morning too. But that one of the things that's really reassuring, especially when you get scared or bogged down by some of those stats that I was sharing earlier about the lethality of eating disorders, is that most people who complete treatment do ultimately fully recover. And that can be helpful to have that reassurance that most people who complete treatment do indeed fully recover. But the levels of care are important, and making sure that you have clients who are in the appropriate level of care is critical. And just like we were talking about this morning, you want to have clients in the lowest level of care possible, that where they can be successful to try to reduce harm. But with things like eating disorders, people do indeed need to be inpatient hospitalized and have tubes when they are in heart failure or kidney failure because they have struggled with an eating disorder for a long time, for example, or they need to be in residential treatment like the place I worked, where they are there 24 hours, 7 days a week for somewhere between 1 and 3 months until they get more stabilized before they are returning back to their home. Or at the PHP level, where they might go to the program between 9 and 2, Monday through Friday, or an intensive outpatient where they might go and say 3 days a week, or once a week therapy. So thinking about what level of care makes sense for your client's needs and helping them get to the right level of care is very important. Because if you're trying to do outpatient therapy with someone who probably needs to be in like PHP level of care, then naturally it might not go so well, and they might need more support than you're able to offer with once a week outpatient therapy. And with eating disorders, there can be movement across levels of care. That doesn't mean that they're failing or you're failing. It's not uncommon to bounce around between the different levels of care with eating disorders too. And we talked some about this, but I also just want to reiterate again that there are these neurobiological influences of eating disorders, and eating disorders typically develop in times of transition, but keeping in mind that times of transition can look a lot of different ways. So some of the common ones are puberty, college, becoming a parent, becoming an empty nester, menopause, trauma, family issues, and grief and loss. So periods of transition can be a precursor for an eating disorder. But if you think about people and clients that you work with, most of them are experiencing some kind of time of transition. And so there's a lot of different things that can be conceptualized as a time of transition that could impact an eating disorder. And that's why it's just so important to also be assessing the empty nesters and also assessing the folks who are going through menopause, etc., for eating disorders too. We talked some about this as well, but I wanted to iterate to you all again that there is a function, there is a purpose of the eating disorder. And these are some of the common purposes, and we'll explore them a bit more, but some of the common functions of the eating disorder are that it reduces anxiety. Much like we were talking a lot about that control. If you're in a world where you have control over very little, where it feels that you have control over very little, if, for example, your parents are getting divorced, or if, for example, you're now an empty nester and your kids are no longer interacting with you in the same regard, that your relationship with food or exercise is something that you have control over, and so it can reduce anxiety, can also reduce fear, can also stabilize mood when depression or anxiety become too difficult to manage. Sometimes the eating disorder helps people feel better. And this can be weird to talk about in this way, but it's important for you to wrap your brain around the purpose and the function that the eating disorder serves for people so that you can help them heal. And if you just directly ask them to get rid of it, like I've heard so many parents and even staff who just don't quite get it yet say, why don't they just eat? And it's like, if it were that simple, but it's not that simple. Imagine like just going up to someone who has generalized anxiety disorder and say, just don't be anxious, just stop. Like it's not, that's not how it works. And so asking clients to get rid of their eating disorder is the equivalent of asking them to temporarily feel worse. Essentially, it's taking away all of their coping mechanisms and they're forced to start over. And it's important that you keep that in mind as a counselor as you're maneuvering through this process, so that you are not someone who says, why don't you just eat? And that you have a more nuanced understanding of how incredibly hard it is and how it has been meeting a need for them for some time, and how to support them in finding other ways to meet that need. Okay, let's pause in, making sure no questions so far. Okay. Awesome. And so I wanted to chat with you all some more about common eating disorder behaviors. It looks very different depending on the client you're working with and their background and what they might be struggling with, but these are some of the common eating disorder behaviors that we see, and things that I think are helpful for you to know and be aware of, because if you notice them, it might signal to you that thoroughly assessing for an eating disorder could make sense. So one of the common eating disorder behaviors is called body checking. And as the name suggests, it is different forms of checking body shape, size. And so there are different variations that you can see show up. But one of the common ones that I've seen, if you're able to look at me on my screen here, is taking your fingers and measuring the size of your arm like this to see like how many times you can move and measure different body parts with your fingers. You can also see body checking show up in a number of different ways, like mirrors. At the residential treatment center, we covered all of the mirrors up. Mirrors were like the worst enemy. And for that stage of recovery, of course, different stages of recovery look different, but for that stage, mirrors were not helpful. And so we had the mirrors in the bathrooms and so on covered up with messages about their worth and so on, so that they weren't body checking when they went to the restroom. And we even had a door that was glass, and we would see the clients walk by the glass door and sort of like check their side profile and so on in the glass reflection. And that was one of our signs that a client was struggling with body checking, one of the eating disorder behaviors, because even though we had things like mirrors covered up, they were noticing when there were other reflections available that they could see and to check their body shape and size. You can also see them comparing themselves to other people's bodies. So comparing themselves to their peers' body shapes is a common one. And that could be through pictures, that could be through looking at them as they're sitting next to them. It's a very common one. Eating disorders are very competitive. And I'd often hear things like, so there was 2 siblings that I worked with for a while, and they would describe it this way too. They would almost compete to see who could be smaller. And so there was a lot of comparing between body shapes and in terms of that too, but it could be through pictures, it could be through sitting next to each other, looking at each other's bodies. One of the things that would be strange to the counselors who started working with us is they didn't experience clients looking at their bodies so much until they started working in eating disorder treatment. And it is not uncommon for clients to look at your body. So for example, I was pregnant when I was working at the eating disorder facility, and all of the time, I felt like all day, every day, I could see the clients looking at my stomach and making comments about my stomach and so on. And so you can definitely notice a lot of the body checking behaviors show up in different ways. But it can show up in a number of different ways as well, including things like looking at old photos of themselves. You even see like a lot of adults do this too, like, oh, look at me when I was 17, if only I could look like that again. And also you can see behavior like changing their clothes a lot and other forms of measuring themselves, sometimes with tape, sometimes with their hands. And then there's a lot to be said with scales as well. In fact, at the residential treatment center, we did not let the kids know how much they weighed. And we did weights because we were monitoring their medical symptoms, of course, but we did blind weights where we essentially the medical staff, the nurses would weigh them and would get their weight documented, but the kids did not have any indication of how much they weighed. Scales are oftentimes a way of checking, and an eating disorder behavior is like hyperfixating on the number on the scale and wanting it to change and often go lower. And in fact, that's one of the forms of like advocating for clients that you might not think about that could be important too. Like I've talked with clients and their PCPs about this client struggles with body image and an eating disorder or disordered eating, what have you. I understand if you need to take their weight because of the medical process to monitor their health, but can we have them do blind weights where you measure it and you get the number off the scale, but they don't see it if that is harmful for their mental health and well-being. There's also other common eating disorder behaviors that we see, like preoccupation with weight, food, calories, carbohydrates. So we would see clients who would have all of the nutrition information that's like on the back of a box or something memorized. And we would intentionally do things like cover up all of the caloric information and nutrition values for different foods and so on, because that could be another common eating disorder symptom where they would fixate and read on those numbers, and it would have tremendous impact on them too. And dieting is a big common eating disorder behavior. And this can be something that stirs up a lot of emotions when we're learning and talking about eating disorders, because people can have lots of thoughts and reactions to dieting. Broadly speaking, dieting is something that can be argued to be a bit of a gateway, if you will, into eating disorders. And you see people often starting with dieting or struggling with dieting, including fad diets or intermittent fasting or clean eating or cutting out entire food groups, like I'm not going to eat carbs or sugar, or becoming vegan or vegetarian. I'm not saying that those things are bad, but we see a lot of people who are struggling with eating disorders who become vegan or vegetarian from a place of an eating disorder instead of from a place of like humanitarian efforts. And so this is really important for you to be mindful of. And when we're talking about biases, this is something that can, many counselors have biases regarding that can trickle into the therapeutic space as well. So if you are doing intermittent fasting and you're working with a client who's restricting their food intake, think about some of that. I mean, that can stir up a lot of different stuff. And so most of us who work in eating disorders are pretty anti-diet, and we just see there's a great deal of problematic things that come up when it comes to dieting. And there's all kinds of research out there that talks about how bad dieting is for the body. And there's so many misconceptions about health. And that ends up being a big part of our work too. So people who, I have a lot of thoughts. I'm trying not to overwhelm you with too much information. Okay. But for example, someone who is in a larger body, if they consistently stay at that larger body, because that's where their body naturally falls, they will have far less health complications than someone who diets and then stops dieting and diets and stops dieting, which is most people's normal routine with dieting because it's not sustainable, restricting food and so on. It's called yo-yo dieting in the literature. And there's a lot of negative health outcomes actually with dieting and yo-yo dieting and so on, compared to if they were just able to be in the body that they were made to be in and that their growth chart shows them to be at. And so there's so many misconceptions about health, and that ends up greatly impacting our work with eating disorders, with our clients, with their families, and even clinicians. I see so many misconceptions. It's one of my biggest pet peeves in our field about dieting and clean eating and stuff. Like when I see TCA emails talking about clean eating, I just want to throw my phone. I get so flustered. And so there's a great deal of misunderstanding that's rampant in our field too, even as helpers. And excessive exercise, of course, is a common eating disorder behavior. In fact, one of the things that people talk about as being most confusing to them with eating disorders is like there's so much language and so much jargon, and I get confused making sense of it. And I totally get that, because sometimes it feels like you're learning a new language with eating disorders. Like body checking being a phrase that not everybody knows, as an example. One of the other things, language-wise, it might be important for you to know is that most of us who work in the eating disorder spaces don't love the word exercise even, because even the word exercise has this connotation of it being negative and punitive and something that you have to do to change your body, or like, you know, I'm so bad for eating blank, now I must go blank. And so there's just so much icky negative connotation even with the word exercise. So you'll find a lot of us using words like movement instead, because that more so aligns with what we're hoping to cultivate for our clients and ourselves, is more of this moving because it feels good, walking my dog because I like the fresh air and taking him out on a walk instead of forcing myself to run. And so being able to shift some of that, because that relationship with exercise and excessively exercising is a common eating disorder behavior. Yeah, Santiago, go ahead.
Sorry, I also wanted to use the raise hand thing because I've never used it. But I had a question. I guess, like, what are your thoughts in your field about BMI?
Oh, we don't like BMI. Good question.
Okay.
No,
Yeah.
BMI sucks.
Okay. Because I work with transgender and non-binary clients, and gender dysphoria has like gender identity, gender dysphoria has a lot to like goes a lot with like body image and stuff like that. And I did have a client who focused really, really hard on their BMI. because they were looking at, well, the average, like, so they were wanting to appear more masculine or be like masculine presenting, and so they were like, well, the average male BMI is this, and this is what I need to get to. So I really wanted your opinion or what your thoughts are on BMI.
Yeah, I have a lot of thoughts. I'll give you my thoughts, and I encourage you all to like fact check me. You can read the science yourself, but here's what I think and what I'm not alone. It's sort of like those of us who work in eating disorders. So we are very anti-BMI. BMI does not have a scientific of roots as you might think it does. In fact, there's a lot of fascinating information about how BMI even originated, and it was more for like commercialization and products than it was actually for science and for medical research, but it stuck around nonetheless. And so it's really problematic, and it's not actually rooted in what we understand about bodies and health and wellness. The numbers are just really skewed and not accurate. And so instead of BMI in the eating disorder realm, we did obviously monitor clients' height and weight and body composition and so on, but we would do so using IBWs or EBWs. So it's their idealized body weight or expected body weight. And so our registered dietitians would get the growth chart. So when you're a little kid and you go to the pediatrician, your doctor will put your height and weight on this growth chart, and our dietitians would get the growth chart from the pediatrician, and they would be able to track this person's growth, and they would be able to estimate what is their body's estimated, expected, idealized body composition, because all of us are so incredibly different and have different backgrounds and genetics and factors at play. And so we would calculate what percentage of their IBW or EBW are they at, and we would set treatment goals related to getting them closer to their body's normal trajectory before the eating disorder, compared to BMIs, which are very, very problematic. Yeah. Thank you for that question. Yeah. Okay, I'm gonna skip forward to something that relates to it. I get excited and I over prepare, so y'all have extra resources, but you might close your eyes. I don't want to give you whiplash. I want to show you something that relates to this conversation that is important. Okay, let me show y'all. Stop share. Okay.
Program is always advancing, but with game-changing formulas that promote
Okay, so related to discussion, because some people might be like, what do you mean the BMI is what? It might be still wrapping your brain around some of this. So what I would love to show you all, I'll share sound. Good. Is a short clip that provides more information about this. So in the eating disorder realm, we strongly believe in health at every size. There's decades of research that debunks a lot of these misconceptions about health being based on body size, and health is really based on lots of other things. And so this is a video that provides more insight into this discussion as we're thinking about BMI and body shapes and sizes, and it gives you more context to further this dialogue too. Okay, so let's check this out together.
There's a big problem at the center of our research on weight and health. What's the problem? Well, picture a society made up of dogs. Let's say poodles are the bossiest group. They're the ones you see down at the doggy park barking at all the other dogs about how to live their lives in order to be healthy. But the problem is, poodles think that every other kind of dog is just a really big, a really small, or a really fat poodle, when actually the other dogs aren't even poodles at all. They're terriers, or mastiffs, or greyhounds, or labs. And all of the thousands of different dog breeds have different lifespans and different health risks. Each one has evolved to use food differently for different specialties at surviving. Some for staying warm, some for running fast, and some for being strong. They're meant to be different sizes and weights. So the poodles think the mastiff should lose weight, but a starving mastiff never becomes a poodle. The poodles don't understand that dogs come in many more sizes than they can imagine in their poodle-centric ways. So this becomes a problem when it comes to poodle science. When the poodles did their weight and health research and made their claim that lighter dogs are healthier and live longer, they weren't comparing thinner poodles and fatter poodles. They were comparing poodles and mastiffs. So the recommendation for mastiffs to lose weight is based on the false assumption that if all dogs reach poodle weight, then all dogs will have poodle health. But once again, a starved mastiff just isn't a poodle. This poodle science doesn't even test whether a starved mastiff lives longer than a mastiff who has enough to eat, because one would have to compare mastiffs who maintain poodle weight to mastiffs that maintain mastiff weight. And it turns out that starving mastiffs regain weight, which after all is a much better thing than starving. But the poodles can only see that regain as a failure of mastiff self-discipline. Look, poodles are great, but poodle-centric health policy is a nightmare. Good science tells us that it's better to recognize and respect the ways we're different, because how we're treated, having good friends, having access to decent food, a place to play, restful sleep, and medical care make a huge difference in our health and longevity, for all of us, whatever our size.
I'm curious, thoughts, reactions to the poodle science video?
Something that comes to my mind, just being a very tall girl compared to Hispanic females, I think, well, growing up, that was like this idea of like sharing how much you weigh, right? Like between friends, like I would always like be losing because, and even until this day, I would say I'm kind of fit-ish. Like I go to the gym and I eat, like I take care of what I eat and stuff. And even then I weigh way more than your average Hispanic female because I'm way taller. And so I think that reminds me of this video, right? Because it doesn't matter how, like, I don't think I would be able to weigh as much as maybe someone shorter than me and feel good about it, or like even be healthy at that point, just because I'm way taller and like my measurements are just like not your average measurements of a female, a Hispanic female. So it took me a long time to like not accept it, but I guess like to be able to like grasp that of the that my weight is always going to be higher, even if like if you compare me to someone else, like you could tell like, okay, like she's not necessarily like fat, right? Like, or she's not necessarily like bigger, but I am taller. So it was a journey.
Yeah, I appreciate you sharing it because it impacts a lot of the clients that we work with in the eating disorder realm too. That there's many people who I've worked with who from the time they were a young person, they were told that their body, that they were overweight or obese, and it's because it's based in poodle science. And if you actually look at their growth chart, it indicates something very different. And so some of these elements in the medical system have tremendous impact on our clients' mental health, and they show up in the therapy process. And being familiar with some of these concepts like health at every size. And I also recognize that when I start talking about some of this stuff, some people are like, what is this lady talking about? So you can do your own research too, and you can read some of the health at every size. I mean, decades of research, but it really impacts our clients a lot. Like the amount of people in larger bodies who go to doctors because they're experiencing symptoms and who are disregarded, and they just say lose weight, and they're actually have a gallbladder problem. It is really pervasive and has tremendous impact on our clients, because then they might on the back end start restricting food so that the doctor will take them seriously in terms of their abdomen pain. And there's a lot of intersection here that greatly shows up and impacts the eating disorder treatment.
Yeah, if I could piggyback off of Sharon for a bit too, growing up like in Hispanic household and being trans too, so I was raised with like female ideation of like what a female body should look like, or like a cis body should look like. I was always typically taller than most of the girls. My shoulders were always wider, and so like the idea of body image too was different because I always did way more than, you know, at the time the other like girls in my class or like my family members. My mom's also very petite. Um, so she had that mindset growing up. But then like I began transitioning and stuff like that. And so like the wide shoulders, granted, I'm not as tall as the average cisgender male, and that's for me to deal with, but um um the idea of how, and even then just trans bodies are always policed in general and how they should look too. Um like the idea of it shifting where now it was like, okay, when before you had come out, like you didn't look the way that I like society or like my family or whatever wanted you to look, but then I begin transitioning and I'm masculine presenting, and it's like, oh, you're doing like you're passing, so you're doing a good job. And it's like, okay, but do I owe you that? Like so it's very it's interesting to see the shift in dynamic too. Um given like whether it be tall or just how like your body structure is in general. So yeah.
Yeah, thank you. I appreciate you sharing. And yeah, it makes sense. It has tremendous impact on everyone and like on your story, on your mental health. So many shoulds and expectations for what the body should look like. And it really impacts people, especially when they feel as though they're not fitting the mold of what the body should look like. Yeah.
I think something that is like really, I mean, sad and disheartening in the medical field is that typically Black women have more cases of fibrosis. And so when they go to, you know, even OBGYNs, they are told, oh, well, you're having fertility issues. You need to start by losing weight. You need to start by managing your health. And you see that gross injustice statistically for sure. Specific to like women's health. Or I should say like biological women's health. That's something that's really prevalent within that minority group.
Yeah, you're spot on. It is incredibly prevalent and it's sad. I've heard heartbreaking stories of people dying who didn't need to die because their medical concerns were disregarded and they were told things like you need to lose weight and then your symptoms will go away. And it's really heavy and it does impact people from certain minoritized backgrounds more so than others, and something that's really important for us to be mindful of. Yeah. Thank y'all for the discussion and being open to this. I mean, I realize it's a lot, you know, but sometimes it's like trying to help dismantle messages that have been around for a long time. Like trying to help people realize dieting's not so great is hard, or trying to help people realize like our medical system's very flawed, and that, so yeah, that, oh, we don't believe in good food or bad food or healthy food or unhealthy food. So there's a lot of stuff in that can really be hard to wrap your brain around when it comes to the world of eating disorders. And so I appreciate y'all being open and vulnerable and being willing to critically think and have some of these conversations and try to piece together why these perspectives are important for serving clients with eating disorders.
I'm sorry. This prompted me to think about just all the new like weight loss drugs that are out there, Ozempic, Mounjaro, Zepbound. And what are your thoughts on the intersectionality of like weight loss, medication and eating disorders?
Yeah, it's another eating disorder behavior. Ozempic is equivalent to like, you know, a laxative or a diuretic, and like it's sad because some of these eating disorder behaviors are culturally accepted, like dieting is pretty culturally accepted. Like intermittent fasting, you know, pretty culturally accepted, only eating healthy foods. And then like Ozempic is being somewhat culturally accepted. But yeah, to me, it is very much so an eating disorder behavior. And not saying that every single person who has taken Ozempic meets criteria in the DSM for an eating disorder, but it is trying to shift the body shape or size using a medical intervention like laxative or a diuretic. And I think it's sad, the toll that I've seen it take on clients.
Well, I guess I'm
Especially-
curious. Oh, I'm sorry. I think I'm curious because it's been so endorsed by the medical world, and even for like children who have obesity, like weight loss surgery, and using these drugs first and foremost in treatment. So I'm like curious how like the use of like those medical tools and counseling can like work together, because it seems sometimes we're so dichotomous in our approaches.
You're right. Yeah. Well, medical doctors also enforce like not eating carbs and eating leafy greens and diet, so I think that there's a lot of problematic things that can come from the voices of medical providers. My thoughts are that I really appreciate being able to refer and collaborate with Hayes informed medical providers, health at every size, which is like what we're talking about with the poodle science and stuff. So there are counselors who can be certified in health at every size. There are medical doctors who can be certified in that. And so I intentionally look for and refer to medical providers who aren't going to do things that perpetuate body image dissatisfaction, disordered eating, and eating disorders, like the HELS certified medical providers. Because I know that those folks aren't going to tell a kid that they're obese and they need to lose weight. I know that those folks aren't going to prescribe Ozempic so that a client can lose weight, or they're not going to shame them about their body shape, even though all of their labs are fine. And those folks are obviously not on every corner. And I'm lucky because I live in Houston, and so we've got options in Houston. But I think that that's an important part of the collaboration piece too, is helping and referring to providers who take a different stance, including OBGYNs and PCPs and pediatricians, who have a different understanding of science and health than others do who are familiar with it. And so those people do exist.
Thank you.
Yeah, good question. Okay, so I think they said I have until 1. Do y'all need a stretch break? I wanted to spend the rest of our time talking about interventions, like counseling approaches. Do y'all need a stretch break before we dive in, or do you want to keep rolling? How are we doing?
Would you all like a 5-minute break? I think that would be good. 5-minute
Okay.
break.
That sounds great. And then we'll come back and we'll talk all kinds of interventions that are evidence-based. So I'll see y'all in 5 minutes.
Thank you.
Yeah, thank you. Do we think most folks are back, or should we wait a little longer? I can't tell. See some folks. Okay. I think it's been around 5 minutes, and I see some faces, so we can jump back in if that sounds okay with y'all.
Yeah, that sounds good.
Okay, sounds good. Awesome. Well, as I shared with you all, I get excited and I overdo it. So there's lots of stuff that I provided to you in those slides. If you want to talk about any of it, let me know. But with the rest of our time, what I was hoping that we could focus in on are specific counseling interventions so you can get an idea of what it can look like in session. They're not all inclusive, of course. There's lots of different ways that you can work with eating disorders, but these are some broad counseling and advocacy interventions, and we'll dive deeper into them that apply to eating disorder treatment. So health at every size, like we were talking about, intuitive eating, mindful eating. Those are some philosophies and strategies that have an evidence base for eating disorder treatment. And then the other things that have an evidence base, and we'll explore those more in terms of eating disorder treatment across the different diagnoses, are acceptance and commitment therapy, ACT, dialectical behavior therapy, DBT, CBT, expressive arts, and then other elements that to be considered and integrated into the process, like considering intersectionalities and decolonizing health and some of the sizeism and understanding of fat phobia and those elements being critical as well. I also very briefly wanted to mention that one consideration, well, more than one, but that you might want to keep in mind as well as you're sort of setting up the counseling space is how to create an inclusive space with your furniture and setup. This is also something that not everybody thinks about, but is really important. So I've heard stories of clients in larger bodies, for example, walking into a therapist's office and realizing that their body won't fit in the chair that's provided for clients. And so I hope that you're really intentional and mindful about the furniture types and places so that folks can easily access them, that you're thinking about the art and visual representations in your space and making sure that they're not just all people in thin bodies as part of the intervention too. But to dive in and think about some sample therapeutic interventions, I'm going to share with you all different interventions that we used in our process of supporting adolescents with eating disorders that pull from the existing evidence base. So not only were we informed from the existing evidence base like ACT and DBT and CBT and expressive arts, but also the agency that I was affiliated with collected lots of research and published numerous articles about the specific approaches that were used and found that it was efficacious. And I can send resources over if you're curious to read more of those. But to give you samples of what it might look like, one of the things that we did with our clients, and all of them loved it, was making mindful placemats. So any guesses about what time of the day is the hardest time of the day for a client with an eating disorder?
I would say hardest time of the day, probably like lunchtime, because it'd probably likely be around other people too.
Yeah, yeah, meals. Meals, snacks, when they have to eat is often the hardest time or times of the day for clients with eating disorders. Exactly. And so when you're thinking about interventions and how to counsel and support clients with eating disorders, figuring out ways to support them during the hardest times of the day, i.e. meals and snacks, is a big part of the work. And so one of the tangibles that we would do with clients were mindful placemats. And so it's trying to help them with establishing coping skills that can help them make it through meals and snacks. As we shared with you all, our clients ate 3 meals and 3 snacks a day, and their dietitians created individualized plans of how much they ate, etc. But that's really difficult to go from experiencing an eating disorder and the struggles at home, coming into treatment and eating 3 meals and 3 snacks a day. And so it's really hard for them. And so the clients would, during group counseling, they would create placemats using various art mediums. So basically a collage, and it could have pictures of people who mattered a lot to them. It could have words of encouragement. It could have goals in the future, like the college they want to attend, etc. And so it was a collage that we laminated, and they had it at the table for their meals and snacks. And when they were struggling, they often would look at and connect to, talk about their inspiration on their placemat as they were making it through the meals and snacks. And we'd also have conversations about their motivations, the people and things that they care about, and other elements of their experience to help them keep pushing through those really challenging times that happened at the table. And for us, of course, the different levels of care will shake out differently, but for us, the clients participated in 2 to 3 group counseling every single day. And they also did 2 sessions of individual therapy a week, 1 session of family therapy a week, and then met with their dietitian every week. So it was a lot of therapy, but we would also have specific groups. Some of them were ACT groups. We had an ACT group, a DBT group, a CBT group, a relapse prevention group, and an expressive arts group, all really pulling on the evidence-based for eating disorder treatment. And continuing this dialogue of thinking about meals and snacks being really hard, one of the things that we did with our clients is before the meals, we engaged in a mindfulness activity, and after the meals, we engaged in a reflection activity that correlated. And these are 2 sample cards of examples that we would use. So, and we had like, I don't know, 30 or more of these as like a card deck, and we'd let the clients choose which one they wanted to do that day. But as an example, and y'all might even practice this yourselves, but as an example, before the meal would begin, you might ask the clients to check in with themselves and to assess their hunger, like how hungry are they, and to identify a number on a scale, especially because part of the treatment process is trying to help clients understand their hunger cues and honor them, and also to understand things like their satiety cues and honor those. Satiety is like when you just have like a hankering for something. Like, I don't know about y'all, but I often, after having dinner or something, will be like, I could go for something sweet, like some chocolate or something. That's what satiety is. And then honoring that, like making sure that if you're having that, that you're letting yourself have that sweet treat. But anyways, to check in with themselves about how hungry they are before the meal begins, and then afterwards to talk about it and reflect together, to assess their level of fullness and to identify how full they're feeling, and to really dive deeper into that. What kind of fullness is it? Is it physical fullness, like in your stomach? Is it emotional fullness because it was a hard meal for you to make it through? Maybe it had a fear food of yours. A fear foods can be foods that they might have been conditioned to believe are like bad or unhealthy. And another example of a mindfulness and reflection card could be focused eating. And so we might lead the client through a silent or focused eating for about 2 minutes of the meal. And we might ask them to focus on one part of the meal, like color, texture, flavor, or something that they might enjoy about this meal. If maybe this is a meal that they used to eat with their family on Saturday nights or something. And then to have conversation about insights that might have came from that, and reflect more after the meal is done. Like, what was it like for you in the silence? What did you learn from the activity? What was it like for you? And to explore that a little bit further. And these are things that feel very different than other types of counseling too. Yeah. And some of the other things will be like, oh yeah, that feels like other stuff I've learned about. And some of this can be a little bit unique and specific to eating disorder treatment. I made, this is a cheesy video back from my time of working at the eating disorder clinic, one of the things that we would be mindful of is what we call table behaviors. And so we talked some about eating disorder behaviors, but there are specific eating disorder behaviors that you can see happen at the table. And so these were lots of examples of those. Well, I think I could quickly show y'all if you'd like to see. Let's see. Oh, it's longer than I thought it was. Okay, well, maybe not, but it's another resource that's plugged in here for you. So there's examples of like microbiting, just taking tiny little bites when you're eating. There's examples like eating really slowly or eating really quickly. There's examples like overusing condiments or spices so that you say it's like inedible. There's like playing with your food or moving your food around. And so this video has examples of for you from eating disorder therapists who I worked with at that time, and dietitian, she's a dietitian, exemplifying for you what those behaviors look like. So if you're going to be eating meals with clients, then you know what kind of behaviors to look for that were common. Okay. There are other things that you can consider and explore in terms of the counseling approach as well. And so there are resources that are really helpful about motivations and phases of recovery. And this comes from the 8 Keys book, which is linked in the resources for you all. But essentially, this is a list of the different phases of recovery. And what we would do is invite clients to explore where they might be at in terms of their process of recovery. And so they might choose one or more of the phrases that describe their motivation, and then to do some more reflection afterwards about why those phrases might have resonated for them. So there's different motivations and phases here, and it can be helpful to explore with your clients where they're at. If you think in terms of like the Train's theoretical model and stages of change, I'm not sure if y'all have learned about that, but it sort of has some overlap with that, but is more specific to eating disorders. But it could be like, I don't think I have a problem. It's my body, so leave me alone. There are people who are a lot thinner or worse than me. Or I might have a problem, but it's not that bad. I only throw up once in a while. My physical body doesn't show anything wrong, so I'm okay. Or it might be, I have a problem, but I don't care. I know throwing up isn't good for me, but it's working for me, so I don't care. I could change if I wanted to, but I don't. Or it could be, I want to change, but I don't know how, and I'm scared. I want to eat normally, but I'm afraid that I will get fat. I want to stop binging, but I can't figure out where to start. Or it could be, I tried to change, but I couldn't. I told myself that I would not blank, but I find myself doing it again. I don't feel like I can ever really change or get well, so I keep trying. I can stop some of the behaviors, but not all of them. I could stop purging, but I won't be able to eat more. My eating has gotten better, but my exercise is out of control. Or I can stop the behaviors, but not my thoughts. I can't stop thinking about food and binging all the time. I keep counting calories over and over in my head, and I still want to lose weight. Or I'm often free from behaviors and thoughts, but not all the time. I feel fine all day, but under stress, I revert back to my unhealthy behaviors. I was fine, but wearing a bathing suit triggered my eating disorder thoughts, and with it, some related behaviors. Or moving into, I am free from behaviors and thoughts. I feel mostly okay in my body, and I'm able to eat things I want and not feel guilty or anxious afterwards. Once I had stopped the behaviors for a period of time, at some point I realized I was no longer having the thoughts or urges. Or I am recovered. For a long time now, I no longer have those thoughts, feelings, or behaviors related to my eating disorder. I accept my body's natural size. My eating disorder is a thing of the past. And so providing a list like this and exploring with clients where they might be in their process can be helpful in terms of figuring out where they might be and motivations and explaining, you know, some of the phases of recovery. It's this balance of exploration and processing and sometimes psychoeducation, depending on the client too. Feel free to ask me questions or jump in at any point in time, but otherwise I just want to keep giving you lots of samples of what it was like working with clients who have eating disorder so you can get a feel for what they can look like. I talked some about this earlier, but the phone clean out was a big part of the work once they got to a certain part of the program. And it wasn't only a phone clean out, but it was also like a closet clean out. And oftentimes it might be donating their eating disorder clothes and replacing them with clothes that fit their body now and so on. So it's essentially just like this process of cleaning out, but we would do things like go through the camera roll. All of the kids had photos that were not helpful. It might have been like a picture of them when they were really sick, or a inspiration photo or what have you. So we'd go through that with them. But so they have to be at a certain level of their motivation and recovery. You're not going to do this with someone who's at like that first example that we named, but as they move through the process and are more open to it, we would do this with them. And they often wanted to as they got a little bit further into their process, but that includes like deleting the stuff from the deleted folder, talking about the social media platforms that they use and going through and unfollowing or muting the stuff that's not helpful, going through the saved items on TikTok, going through My Eyes Only if they have it, looking the private Safari, Pinterest boards, and deleting any of the non-recovery focused apps. Oh, we hated Apple Watches. Apple Watches were banned. Fitbits banned. So a lot of those things are just not helpful for someone who has an eating disorder. And we would do things like, well, those were not even allowed in our facility. They were like, nope, not happening. And other things too, like coffee, no go, because that's an appetite suppressant. Gum, no go, appetite suppressant. So there's different things like that as well. But for this, we were going through with them, and we weren't forcing them, but this was a collaborative process. Most of them have things like exercise or calorie counters, any health related apps, and clearing those out. Even thinking about secret folders on the phone and clearing those out, and giving them a list of recovery focused social media accounts. So these are some of them that we would give, and replacing them. So we don't want to just take things away, we want to replace them. Just like we don't want to take eating disorder behavior away, we want to replace it with other more adaptive coping skills and resources. And we do a similar process with the phone clearing out, because if you're going through social media every day and you're seeing all of these things, it can be incredibly activating for someone who is still healing or even recovered from an eating disorder.
Can I ask, has there ever, because I've seen accounts online where their entire existence is like for like eating disorder behavior and things like that. Has there ever been an instance where you've just had like, we got to delete the whole account? Or okay.
Yeah.
Huh.
And most of the time, I mean, everyone could be at different stages of their recovery when like we're working on things like this, but when we're doing this kind of intervention with clients, they're at this stage where they're like, I have to delete this and start over. Like I am creating a new identity myself, and so none of this no longer fits. And you know, we might save like a picture or two that wasn't disordered, but was more like, you know, special memories to hang on to. But yeah, it isn't uncommon for that kind of thing to happen, where we are really scrapping and starting anew. And that can be a beautiful cathartic therapeutic process in and of itself, as they are forging a new identity that's no longer their eating disorder. Yeah, it is really cool. Gosh, is it so heartwarming when a kid looks at you dead in the face and is like, I need to delete like all of this. and start over. Will you help me? Yes, let's do it. Yeah, there's a lot of hard moments, don't get me wrong, but there are also those really beautiful moments where you can see them healing and growing and changing.
Thank you.
Yeah, thanks for the questions. I appreciate them. Okay. Other things that we talk a lot about the eating disorder voice compared to the healthy self, which has like a parts work elements if you're into like IFS or anything like that. There's definitely some flavors there, but that's super common in the counseling process as well, is helping clients identify and distinguish what might be coming from their eating disorder part compared to what might be coming from their healthy self. And really the goal is to crank up the volume of the healthy self and crank down the volume of the eating disorder part. And so this is a therapy assignment that comes from that same book that I mentioned, The 8 Keys, from Carolyn Costin. But in this intervention, it involved helping with providing some of that education first, that people who are diagnosed with an eating disorder, they have an eating disorder part and a healthy self, and trying to build some awareness around what are the messages that come from your eating disorder part. What does your eating disorder part tell you compared to what is your healthy self share, and how does it counter those messages, and really turning up the volume, if you will, especially as you're moving through the process of healing. So you can do things like pick a time when you are having eating disorder thoughts and get your journal and write about those, and dialogue some of the flow between the eating disorder part compared to your healthy self, and really reassuring the clients that that process gets easier with time. And then if they get stuck, then they might think about what they might say to somebody else that they cared about, if they were saying things that the eating disorder part says to you, and making sure that they end the dialogue with the healthy self getting the last word. We would also do things like do this with chairs and group though. So we might pull up 2 chairs in the middle of the circle during a group session, and have 1 chair represent the eating disorder part and 1 chair represent the healthy self, and invite a client to move from 1 chair to the other, and to sort of exemplify this dialogue that happens internally for clients with eating disorders for the group, and so that the group can process that and support them, and help with strengthening the healthy self. And also just this language ends up being really helpful. You'll hear kids, like clients, start to use this language themselves. So like, my eating disorder voice is saying this, but my healthy self is saying that. Like, you'll hear them use this language as they're making sense of their experience, which is helpful in increasing some of that awareness. And because there can be so much enmeshment between like believing the eating disorder is their identity, and that it's not the same thing as the self, as we're differentiating the two. And also from the family perspective, there have been many families that I've worked with who are like so angry at their child, and not understanding why they would say things or do things. And this can be helpful for the psychoeducation with the families too, is like there's a difference between their eating disorder part and their healthy self, and we want to love on that healthy self, but the eating disorder voice is going to show up sometimes, and that is not your child, though. That's their eating disorder. But like, to help with some of that psychoeducation can be really important when you're thinking about the family or the caregivers, if applicable, too. Oh, I jumped ahead of myself and talked about this. Yeah, but you can do some cool work with empty chairs if you're into some of that, like some of the Gestalt work and so on. But one of the like go-to seminal books on eating disorders that it's actually like written for lay people by someone who experienced an eating disorder, is called Life Without Ed. by Jenny Schaefer. There's a picture of it on the screen there for you. She talks about how her therapist did this with her and used an empty chair and to dive deeper into the eating disorder part or voice. Counseling interventions can involve naming that eating disorder voice. So Jenny Schaefer named it Ed, like eating disorder Ed. I've heard people name them things like Rex, like anorexia Rex. And so sometimes that is part of the process too, because we're really trying to differentiate the self from the eating disorder voice, because that is an instrumental part of the healing process. But this intervention really is about distinguishing the self from the eating disorder voice, and it can be really helpful when the eating disorder voice is very loud. Sometimes kids, after learning this language, would come up to us and they'd be like, "My Ed's being really loud right now. I could use someone to talk with me and distract me," or "Would you play bananagrams with me?" Or so even like having that language really was just so helpful, and you can use it and adapt it in different ways for individual counseling or group counseling or family counseling. There are other interventions that we invited clients to do. Our program had levels, so like level 1, level 2, level 3, and they often graduated and like were discharged when they were at level 3. And so part of the process was them doing specific therapy assignments and different levels. And so some of them involved letters like this. But for this, what clients can do is to write a thank you letter to your eating disorder self, letting that part of you know that like you're like thanking it for everything that's done for you. And some people can be like, "What? We're thanking the eating disorder? What are you talking about?" But like we were talking about earlier, the eating disorder did serve some kind of purpose. And when there's so much shame and judgment and anger towards a part of you, but like that eating disorder voice, that can be counter productive for the healing process. And so taking the time to think that the eating disorder for like the purpose that it served, like helping you make it through your parents' divorce, helping you deal with anger, helping you feel like you mattered. But then moving into the process of what would you have to feel without your eating disorder, and like sharing some of this, because this really gives the clients the space to reflect on some of the purpose that was served. Sort of like thank you and then goodbye, which is what you would move into with the next step, is after thanking it for the purpose that it served, moving into the process of saying goodbye to the eating disorder part. So we would invite them to have their healthy self tell their eating disorder part what it's done for you, but also the price you've had to pay, and move through the process and saying things like, "I'm not going to be following your directives anymore," and moving through this process of continuing the dialogue. But it can be an exercise that can be helpful as you're moving through the process of thinking and saying goodbye, and using that healthy self to maneuver this process too, about how you can take care of yourself in a healthier way. And you've got other support system now, or you're no longer in that situation, what have you. But not in a hostile, abusive way, but in a gentle, like, "Thank you, we don't need you anymore" kind of way. And then there are other interventions that can be helpful too. Like exploring your reasons for not reaching out. And so this is another resource from that Key 7, the 8 Keys book, where you invite clients to explore their reasons for not reaching out for help, which is a very common theme for many clients with eating disorders. and helping them with exploring the reasons that they didn't reach out, and then to write sort of counter arguments for the reasons that they didn't reach out for help. Like, I don't deserve help. And then writing counter arguments with, I do deserve help. Everyone deserves help when they're struggling. And writing about why you are deserving of help, why you should reach out, helps with reinforcing that healthy self. And it makes it easier to do that. Whereas sort of trying to strengthen the voice, turn up the volume, as I was talking about with the healthy self. And so this is another way of practicing that. So these are some of the common reasons for not reaching out. Like, I don't want people to know how much I need help. I'm ashamed. One of the really common ones that we heard a lot was, I'm not sick enough, even when they were sick, and their labs were off and so on, saying, well, like, I haven't been intubated, so I'm not sick enough. I don't need help. Or I don't know what to say. I don't see how anyone could help. I don't have anyone to reach out to. People haven't been there for me in the past. I don't want to be a burden. I'm afraid to rely on others because they won't always be around. I'm not sure that I want to be stopped. I'll feel worse if I reach out for help and it doesn't help. I tried and it didn't work. I should be able to handle things on my own. So these are some of the reasons that could come up for not reaching out for help. And so exploring that could be important in the therapeutic process too. Oh yeah. That's shame. Yes. And then your worst eating disorder day. This could be helpful to explore with your client in session, or sometimes could be written out and processed in session. There's lots of different ways that you can maneuver all of these, but just to give you some tangibles about what the process of helping a client heal can look like. Thinking back to their worst eating disorder day, or if they're having a hard time thinking about a really bad day, and writing down in specific detail the day's events, like, what'd you eat, how much did you eat, what behaviors happened, like restricting or purging, the details there, any other eating disorder behaviors like body checking or exercising for compensation, and writing down your feelings before, during, and after. Writing down any lies or dishonesty that's involved, since, like I was talking about, eating disorders thrive in secrecy. So maybe they lied to their friends and said they already ate, and then they lied to their parents and said they already ate. How it affected them, how it affected other people, and really being honest, because the information is for them. And really, like, writing it down and honestly, transparently looking at it is not something that many people have done before. And so after the process of exploring this, then sharing it with another person, sometimes sharing it with their therapist, sometimes with their group therapist. I mean, the process will look different depending on the client and where they were at. And counselors would use their clinical intuition to make the calls about when this was done and how it was shared. But the sharing it part could be helpful as sort of that impetus for a new beginning, knowing that, like, fully recognizing the impact of the eating disorder by writing it out and being really honest and transparent, really looking it in the face, but also knowing that the eating disorder is not who you are, nor who you're meant to be, often comes up through this process of reflection. And with that, there's other interventions that could be considered, like day in the life when I'm recovered. And so you might invite your client to imagine a day in the future when they're free from their eating disorder, and really dig deep into that. Like, what does it look like? Where are you? Who are you with? What are you sharing with others? What meaning are you experiencing in your life? And really to try to get specific with that imagery and really visualize it and have this clear image of what their life will be like. And writing it down can be really helpful to help them stay grounded in their motivation on the hard days, the hard meals with fear foods, etc. Similarly, you can invite them to reflect about their future self. They could write a letter, they could talk about it with you. But to think about themselves a few months into their recovery, getting a supportive, encouraging letter from yourself to yourself, what would it say? And to remind yourself of all the things that you've learned, how far you've come, how it feels to be where you're at, to have some of that inspiration that can help give you perspective when you're struggling too. And this probably isn't surprising to you, but really exploring and strengthening support systems can be a part of the therapeutic process as well, making sure that clients have a list of support people who are available to them, who they can reach out to when they're struggling. Oh, and hopefully you as their counselor will be one of those people, but also to have other people who are there for them who they can reach out to as well. And you might ask them to do something like to approach at least one person on your list within the next week to really help them strengthen those skills of like reaching out to other people and letting other people in, letting other people help them. And you might do things like ask the person if they're willing to help you, just connect and be with the person, talk to the person about specific ways they can help you, or try to anticipate barriers that might make it harder to let them know when you're struggling and talk through those. Food rules. I don't know that it explicitly came up, but food rules are very common for clients with eating disorders. And so these are if you just say food rules, the clients will know what you're talking about. But for you all, food rules are like rigid rules about food. And clients with eating disorders typically have food rules. And so it might be something like, I only eat blank number of calories a day. Or it might be something like, I don't eat carbs. Or it might be something like, I can only eat blank if I do blank first. So clients will have food rules. And so exploring those food rules with them is a big part of the process as well. So asking them questions like, what are the food rules, if any, you have about food? What are your thoughts and feelings about food? How's it impact you? To better understand their inner dialogue about food. Clients will often have fear foods and safe food. Again, you don't have to explain that language to them, they'll know. But their fear foods might be foods that are really hard for them to eat. And for the clients who have an eating disorder diagnosis like anorexia or bulimia, where there might be that fear of gaining weight, their fear foods might be related to foods that are conceptualized as being bad or unhealthy, like carbs or desserts or bread or what have you. And then their safe foods are, I'm stereotyping, but it's not always this linear, but might be things like green foods, vegetables, things that are typically categorized as healthier. But again, it's not that rigid. And that's why it's important that you explore with clients, what are their food rules, what are their safe foods, what are their fear foods. I didn't talk a ton about ARFID, which I'm realizing it might be helpful for you all to know about too. For avoidant restrictive food intake disorder, ARFID, it's a different eating disorder. And so there are also food rules and fear foods and safe foods for ARFID, but ARFID does not have the fear of becoming fat like some of the other eating disorders do. ARFID is often not getting adequate nutrition, but there isn't that fear of fat tied to it. It can often be things like there's a high comorbidity between ARFID and like autism and sensory issues. So they might have a hard time with eating certain textures of food. And as such, they only eat a certain brand of chicken nuggets and a certain brand of pizza, and foods outside of that they don't eat because of some like sensory dynamics. But they can ultimately be malnourished or be struggling as a result of some of the sensory side. But it can also have different presentations, like a trauma focus. So if someone, when they were 3 years old, had a really scary event where they choked on a food and like something bad really nearly happened, like maybe they had to be hospitalized, or maybe an ambulance came, maybe they turned blue. If there's a traumatic event regarding food, then sometimes we can see ARFID show up later, where they have pretty particular fear foods, safe foods, and food rules as well. But again, that looks different. It's not the same as some of the other eating disorders that have the fear of being fat. ARFID takes a different presentation. And that's important for you to consider as well. Also, this is maybe, getting a little bit into the weeds, but you'll even hear some clients who have an eating disorder like anorexia, for example, tell you that they have ARFID. And so there's interesting stuff that happens. So I'd encourage you to make sure that you're doing your own assessments and thinking through it as well. Because there's some, interesting, tricky nuances that start to come up as you get deeper into this process. Okay, I'll talk through a few more with y'all, and then I'll make sure that we've got a few minutes for questions. So I really appreciate the questions and dialogue that's been coming thus far. And as shared with you, I put the PDF of these slides in the chat with you, so you've got extra resources available to you too. But you might explore, I don't love this language, I don't think I've ever used this language, but you might explore some of the recovery sabotaging behaviors. I think that feels too like punitive, but anyways, you might explore some of the behaviors that they're still struggling with and support them in that process. And these are some of the common ones. I mean, we've been talking about many of them, like some of the table behaviors, or comparing yourself to others, body checking, keeping clothes that only fit when you are not well, hiding food, not telling people about, like, important people in your life about your eating disorder. So you might explore some of those behaviors with them as well. And there's some mind-body exploration that's really important too, because there is this reconnecting to your body that happens through the healing process for eating disorders. This is a list of the real issues. Eating disorders are interesting because it's about the food, but it's also not about the food. Like, there's other stuff going on and impacting it too. So these are some of the common real issues, like poor self-worth, discomfort with my feelings, belief in a myth, need for distraction, filling a void, need for perfection, desire to be special or unique, drive to be in control. And so exploring some of those real issues that might be at play with your clients can be really impactful in the counseling process too. And there are some others like desire for power over self, others, family, or life, desire for respect or admiration, get difficulty expressing feelings, need for a safe place to go or lack of coping skills, lack of trust in self and others, intense fear of not measuring up. So those are some of the common real issues and the topics that you might explore with your clients in session 2. The clients normally like this one and they think it's silly because we start talking about aliens and stuff, but this is an intervention where you invite clients to try to see their body from a different perspective. So you might give them a prompt like to imagine that they are an alien from a different planet who has inhabited a human body for the first time on Earth, and you need to send back to the planet a description of the body. And using your body as a template. And then you might invite them to reflect on the body, write a description as the Earth suit you have inhabited on the planet. And it's important to approach this description using objective descriptions, not judgments. And if you find yourself writing anything derogatory about your body, stop, reframe, and write that part again. And this can be part of the process as well, since many of our clients have skewed perceptions of their body or body dysmorphia, or you're seeing their eating disorder show up in terms of that perception being skewed. And so this is a way in which you can be kind of like playful and silly because you're talking about aliens, but also help them with shifting some perspective too. Okay, and then there's other resources that y'all may have been exposed to, or I'd encourage you to explore further, from like DBT or ACT, that really seamlessly fit for this population, like eating disorder clients often have a hard time expressing their needs and communicating with others. Hopefully you've been hearing that theme. And so things like the Dear Man from DBT are really helpful, or Radical Acceptance from DBT is really helpful. And there's more resources plugged in here for you, or pulling from ACT and doing things like a values card sort and exploring their values and how it impacts their life and their recovery and their strengths and challenges. And cognitive diffusion, also coming from ACT, doing things like this leaves on a stream meditation, maybe y'all have been exposed to before. All of those things really apply for this population too, and being able to put the eating disorder thought on the leaf and let it float away compared to picking it up between your eyes and being hyperfixated on it. So there's other things that you may have already been exposed to in your process that you can use for this population that make a lot of sense too. So we've got 5 minutes left, I think. And so I wanted to stop. I feel like I've been rapid firing, so I want to check in with you all. What are you thinking? Thoughts, questions, comments? How are we feeling as we're talking through potential interventions for clients with eating disorders?
I was thinking ACT initially when you had started the presentation, when I was thinking of what I would utilize for someone with an eating disorder. So I was happy to see it in the presentation for sure.
Yeah, ACT is a very seamless fit. That's why we had like a whole group every single week where we were using ACT. And there's so many of the concepts that just fit so seamlessly. And I think that hopefully that empowers you all too to be like, okay, maybe I was at a 1 or a 2, and maybe eating disorders are kind of scary, but I'm saying, okay, I know something about ACT. I can use that and apply that in my work. Oh, I know something about DBT. I can do some of this. So I also hope that y'all are feeling like I can do this. I can work with clients with eating disorders. Yeah, thank you. What other questions or comments?
I really I do feel a lot better, like at least in the approach to it. Everyone who knows me knows I use ACT a lot. So and I knew that it does work pretty well with eating disorders. I really did like the thank you letter as like the exercise, because the shame part of it is what really drives a lot of the disorder and just like the behaviors in general. And a lot of people don't think about it. They think about like there's something wrong with me, I need to fix it and get rid of this thing, versus like this was a part of me and I learned how to heal through it. And the thing with Act 2 is like letting things like flow and come and go. So I really, really enjoyed that. So and everything else. So thank you.
Yeah, of course. I'm glad. That's my big goal. That y'all are just like, phew, I think I can do it. You don't have to be an expert. I don't even feel like an expert, though. I guess technically I am, but like it's okay. There's so much learning and growth to happen through this process. But many of the skills that y'all already have, many of the things that you've already learned can apply with some fine tuning to this population. And that's something I'm really passionate about you all knowing, especially because we have such a lack of providers who will support clients with eating disorders. And I'm not saying to work with a client who's in kidney failure as your first eating disorder client, like, please don't do that. But I hope that y'all feel empowered enough to be like, I don't have to turn everyone away, because there's often not someone to turn them away to. And to, of course, make sure that you're getting appropriate training and supervision and consulting if when you have clients with eating disorders, but y'all can do it. And in fact, we need you to do it. The eating disorders numbers rise every year, and we still don't have enough providers. In fact, I hear far too many people say, I don't work with them. And there's not a lot of populations where that kind of thing is okay. Like you can't say, I don't work with those people. But eating disorders is still one of the areas where I hear many clinicians say things like, I don't work with those people. And I really hope that y'all are like, nope, we work with those people. We work with all people. We just stay within our scope of practice, and we make sure that we're adequately trained and getting supervision and consultation. Okay. Oh, I got a message that said that we can stay 10 or 15 minutes more. Would you all like me to tell you more interventions? I got bunches of them in here. Or how are you doing?
Yes, more.
Okay, more. Okay. Sounds good. So I will use our next 10 or so minutes. What I can show y'all next, yeah, and I'm happy to put the slides in the chat again. Okay. So, I'm going to jump around for a second. I'll show you some stuff that's in here. I mentioned that mirrors are a really hard point, and so that might be something that you explore with some of your clients. I have really mixed feelings about affirmations. Sometimes they're helpful for some clients, and sometimes they are not helpful for other people. And so you might just explore that and keep that in mind when it comes to the clients that you're working with. Sometimes doing things like helping them cover up their mirrors with inspiring or motivating comments can be more helpful than them looking in the mirror. But I'm sorry, I'm jumping around a tad here. I also, something that I wanted to share with you all as well that we haven't yet discussed is something that I use a lot in my practice is body neutrality, not body positivity, body neutrality. And many of us who work in the eating disorder space believe more so in body neutrality and body acceptance than body positivity, because for many clients who have eating disorders or body image struggles, it can feel incredibly unrealistic to be in a space where they can say, like, I love my stomach, I love my thighs. And like, even me, I had a baby 2 years ago, and it's hard for me to look at my stretch marks and be like, I love my stretch marks. There can be this disconnect where it can feel pretty unattainable or unrealistic for some people. And so body neutrality is often something that can feel a little bit more doable and realistic. I'm not saying that body positivity is bad. It's beautiful for the people it works for. But sometimes I see clinicians who try to like cram body positivity down the throat of someone who has an eating disorder, and it doesn't quite align. But something like body neutrality and body acceptance can be a more seamless fit. So instead of going from I hate my stomach, you can shift to focusing on the body's function, or accepting the body, or having a really neutral stance about the body that is very fact-based about the body's function. And so for me, for example, with my stretch mark example, it's like my body brought a baby into this planet. That's pretty cool. Or like my body was able to feed my child. So it's more about the function and accepting the body more so than, oh my gosh, I love my stretch marks, because that can be very unrealistic and unattainable. And I share that with you all to think about that as well, because maybe something like learning more about body neutrality and body functionality, body acceptance might be helpful frameworks for you to use with your clients compared to a body positivity. But again, and body positivity can work for some people, but not all. Just like, I think we can make the argument that some interventions work for some people, but not all interventions work for all people. Okay, with the rest of our time, I wanted to speak more about expressive arts interventions that you can use, because they can be really helpful for clients with eating disorders at different stages of the recovery process as well. Especially, I mean across the board, but when you're thinking about folks who are at different stages of the process and different levels of nourishment and so on, it can be helpful to have other tools in your toolbox like expressive arts. I'm a registered play therapist as well. And so you can probably feel some of that from what I'm going to share with you next. But I have found sand tray to be incredibly impactful for clients who are navigating eating disorders. And there are even miniatures like this little set that I put the picture of on the slide that have scales and toilets and mirrors and common fear foods like desserts and fast food that I have in my office, and that I've seen clients do really beautiful healing work with, using the sand tray to process through their experience. And so sand tray is something that you need to be, of course, be trained in or have supervision consultation in and learn more about. But if you have that support, then you can do sand tray directives like build a tray about what you see when you look in the mirror, or build a tray about how would your life be different if the eating disorder was not in your life. Those are more directive sand tray interventions, but you can also do the more broad open ones like build a world. And someone with an eating disorder will often have elements of that shows up in the world that they create in the sand tray, especially if you have resources available like some of those that I've got. I also something that's really important to me is to have lots of different representation of body shapes and sizes. And I happen to have some with me right here. So like I have miniatures that are in different shapes of bodies. So they're not all miniatures and like smaller bodies. I have miniatures in different body shapes and size. And this, like having that diversity in the miniatures that are available so that clients can find miniatures that they feel connected to is important as well. I've walked into many people's offices and I look at their miniature collection. I'm like, every single one of these like toys or miniatures that you have is skinny. What's it going to be like for a person who is in a larger body to come in here and to build a tray? And what's that going to be like for them? So those are some things I consider. Oh, this is also one of the letter writing, is writing a letter to your caregiver and exploring that. It was a really impactful part of the process too. Like telling them what you're thankful for, what you would like them to understand about you. Really beautiful stuff came up there. How you felt about your relationships, because there's often a barrier of understanding between adolescents with eating disorders and their caregivers too. We also would do things like table games. So there might be 8 clients sitting around the table. Of course, this is residential, so it's different in other levels of care, but still could be helpful for you to know about is like to have different tools in the toolbox to help clients make it through meals. One of the things that clients really liked a lot was to have games that would help distract them. Or like keep them focused on something else while they're chewing and eating to help them make it through the meals. We like to use this in moderation because we also wanted them to have other tools in their toolbox. But there's a movie game where you could have one person decide on a movie and the other people would ask them a question like, can I bring, and then to name a topic. So you might say, if we're thinking about Finding Nemo, if y'all have seen that movie, you might say things like, can I bring a turtle? Can I bring a blue fish? And you're asking questions that are like hints towards what movie it might be. And then you're trying to figure out what movie it might be. So it's this like silly little movie game, but it can be helpful and fun to help them persevere through a really hard time. Again, we like to use that in addition to other tools to help them make it through meals. Much like people, places, and things are important to explore in substance use relapse prevention, they are also important to explore in eating disorder relapse prevention. And so I would do things like, remember, this is a play therapist in me, but I would do things like have Legos, and we would build recovery Legos, or what I called them. So first we, like you could do it individually or in a group setting. I normally do this one in a group setting, but we would explore the people, places, and things that are remind us of eating disorder and might trigger relapse. And so the clients would name people, places, things, maybe certain clothes, maybe scales or Fitbits or what have you, and reflect on the things that are not so helpful. And then afterwards, we reflected on the things that were helpful for the recovery process and built Lego representations of the helpful ones. I don't suggest building the not helpful ones, but just the helpful ones. And so they would build Lego representations of the people, places, and things that are helpful for their recovery. And we shared those together. And I talked some about body neutrality and how it really is that accepting the body as a vessel that carries them through life and not attaching positive or negative feelings to their physicality, just function, neutral kind of statements. And so we did things like body neutrality Jenga, where I've done it different ways depending on what stage of the process clients were in, but you might have them share a body neutral statement with each Jenga piece that they pull, or you might write those on and like tape them on the Jenga pieces if they're still learning some, and invite them to read it and share on it, reflect on it together. So there's different variations of body neutrality and ways you can explore that together too. Perfectionism is very common for clients with eating disorders. And so part of the work can be helping them heal from the perfectionism at play as well. And so there were different variations of that came up in the therapeutic process. Things like, do y'all know who Bob Ross is? I feel like most people do. Yeah, okay. So we, in one of the expressive arts groups that we did, we were trying to help clients embrace the mess and tackle perfectionism. And so we did one of the Bob Ross videos together, one of the like happy little tree videos. And of course, it was a mess, and none of us are Bob Ross as much as we would like to be. Anyways, but we used that as a process of having a really beautiful dialogue about embracing the mess and the perfectionism that was showing up, because many other people in the group were getting frustrated at first, and they're like, mine's not looking as good as Bob Ross's, like, gosh darn it, why not? But through the process, you could feel the group shift and being able to be like, well, it's a really cool painting though, and I'm actually excited to hang it up in my room, and it's still beautiful, and to be able to embrace the mess and tackle perfectionism through the process of art together is fun and enjoyable. Also, masks are super common in eating disorder treatment. Doing like you could do a side-by-side drawing, or we would normally have the mask like the one on the left, and on the outside they would decorate it with how the world perceives them, and on the inside they would do their authentic self, and we would process that together. We would also do salt paintings. You can Google how to do them. It's pretty easy. You just need like watercolor paint and salt and glue. And we would write strength words like, so some of the common ones were words like brave or enough. And clients would really come up with a word that captures their strengths, what they want to lean on and be reminded of. And we made paintings of those. And some people kept them, near mealtime, and some people kept them in their room as reminders. Okay. I'm gonna pause there, and yes, would love to check in one final time. I'd love to hear final thoughts, questions, and yeah, any that might be there. Well, I'll pause for a second. Any thoughts or questions?
Have you ever worked with or worked at a facility where like edible art therapy was utilized? We did that at an RTC that took in clients with eating disorders. And that was something that a lot of our clients with eating disorders really liked, which we were nervous to try because we weren't sure how the reading would be. But it was a little experimental, but it went really well. So I was wondering what your thoughts on it were.
What were they eating?
So like they would build like turkeys out of like a strawberry pretzels. They would dip it in chocolate. We would have them like dip dip strawberries in chocolate and then spell something on the strawberries, or make a little cupcake and then write an affirmation on the cupcake. They did not have to eat it afterwards, of course. Most of the time they did, or it was just kind of like, it almost felt like exposure therapy too. Like they got to touch the food, build something out of it.
Yeah. We did a variation of it that looked a little bit different. So we didn't in like the therapy context exactly, because the meals and snacks were scheduled. They were on certain meal plans from the dietitians and so on. But they did always have a cooking group every week where they actually were in the kitchen cooking something together. And then that was a lot of the like food exposure, but the dietitian was very actively involved in that process. And then it would be optional to eat it as part of their meal for dinner, or they could stick with their normal meal plan. So there's definitely elements of that happened within our cooking group. That was something that happened once a week. Because you're right, like that exposure and touching food, being involved with food, it can be really impactful and therapeutic too. I think there's a lot of potential for it to go awry. So it just has to be done smoothly. Yeah.
Yeah, for sure. Like the mental health technicians could not leave that group alone, for sure.
Yes.
The
Yeah, yeah.
therapists were there.
Yeah, right. And that's why our dietitian led that one. Yeah, and cooking and like very food focused too. Yeah.
Cool, thank you.
Yeah, thank you all. Well, last question for y'all, if there aren't any other questions or comments at this time, I would love if you all would be open to sharing like a final word or phrase with me. Like what's our conversation today been like for you, or any takeaways, or something you want to think more about or try? If you want to share a word or phrase in the question in the comment box, or if you want to unmute and share it, and then we can wrap up with my part.
I think mine would be confident and competent. I feel like I just need a little more interventions and maybe theoretical strategies to lean into, and that would have made me feel more comfortable.
Yeah, that makes total sense. Yeah, we're scratching the surface, but there's definitely more to keep learning and building up. But I love it. Confident, competent, beautiful. Thank you.
I would say enlightening and eye-opening too. For not just like for clients, but also for like myself too. So
Thank you. I appreciate it.
Yeah, I just want to share how helpful this has been. We really appreciate the resources you sent us and really just kind of showing us that eating disorders can occur with a variety of populations, with all ethnicities, ages, genders. And so this has been very helpful. The statistics you provided were really informative, and then also really going in depth on how to recognize our own biases, how to be mindful and sensitive to some of the language we use, and then also with the various treatment interventions, you talked about how DBT can be applied, or acceptance and commitment therapy. So it's been very, very helpful, and we really appreciate the resources that you've sent us.
Thank you. It was a pleasure. And I love some of the comments in the chat. Thank you for sharing those with me. And it really has been an honor. I love the opportunity to share this with folks who can go out and have such impact with the clients that they're going to serve. And my email is on the information, and I think that you can get it from the other folks if you need it too. But if you have questions or want to talk anything through, you're welcome to reach out to me as well. I'd love to be a resource for you all in your journeys too.
Thank you. And I wanted to mention to our students in Tex-CHIP, we do have that book that Dr. Horton mentioned, the 8 Keys to Treating Eating Disorders. That is available to us now, and you can pick it up front. We have it in the front of where the graduate assistants are, kind of where Rachel is. But just contact us and please pick it up. So we have it available for you all.
Awesome. Thank y'all. Do you need anything else from me?
No, thank you so much. I think we're gonna take another break, and then the students can stay behind, and we're gonna show them a video for our virtual simulation activity that we have prepared. But thank you so much, Dr. Horton. We really appreciate all your help.
Thank you, Dr. Horton. Thank you. Thank you so much, Dr. Horton.
Yeah, thank you. Oh, it's so nice to meet you. I hope to see y'all around.
Yes.
Okay.
Bye.
Bye, everybody.
Okay, everybody, why don't we take a 10-minute break, and then when we come back, we'll have our final activity for you all.
Natalia, did you have a question?
If we're not students and we were here for the CEUs, do we stay or do we go?
It's up to you. This last hour technically doesn't, like, we're not giving CEs for this hour, so you can leave if you like, but you can also stay. So it really is up to you.
Okay. Well, I would like to say thank you for the invitation. It was great. And I'm gonna head out because I gotta go do something with this cat.
For sure. Thank you so much for joining us. We'll be reaching out for the CEs, okay?
Thank you.
Thank you
have a
for the
good day.
presentation.
Yeah, for sure. Thank you. Bye.
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 Okay, can y'all see my screen?
Yes.
Okay, just so I'm clarifying, because I have a split screen going on, so you're not looking at the case study, we're looking at a video, right? Okay, thank you. So, this is a really short clip. So this time around, instead of pausing it, and asking process questions, I'm just gonna play it straight through and just ask questions at the end. It's only gonna be about 4 or 5. Just again, we're gonna start it, try to get through it, so that we can watch the whole thing, all right? So let me know if y'all can't hear it. Hopefully you can. Okay, that you're taking into account concerns because you've been experiencing symptoms of depression. So tell me a little bit more about that.
Yeah, so like I said, I'm 23 and
Okay, y'all can hear, right?
It's a little quiet.
Yeah, unfortunately it is. I have my volume all the way up. Let me try to see if I can when I share the screen.
I think there's a way where you can sync it to Zoom so that it comes like through our speakers, like it's part of
Yeah,
your.
I think there we go. I found it. That's what it is.
Okay.
Thank you. And if you still have trouble, let me know. So this is our client, our unnamed client, okay? So if you know who it is, just, this is all a skit. And it is to do with eating disorders. And so just kind of like keep in mind things to listen out for and what the diagnosis might be. Okay. Let's see if this is better.
and I just graduated college, and so I'm kind of on the prowl for a job. Trying to get that first one is always a little bit hard. I was also a collegiate athlete, and so that has been almost the purpose that really got through college, of just trucking on with academics and all the other things that kind of happen within college life. So since that, it's just been really like purpose just isn't there, and so I've just been kind of sad about a lot of things.
So it sounds like you had a lot of your identity put into being a collegiate athlete.
Yeah, like it's kind of the cliche thing of I don't really know who I am without my sport. So yeah.
Yeah. And so when you said that you've been experiencing depression, like what's going on with you, like in your body? Like what are you feeling?
I mean, one of the things has been like really lethargic, like really like my body doesn't want to go like do things. I have a sense of like laying in bed maybe way too long, or just being on my phone and not being like, instead of go looking for jobs, I'm more just on my phone, either just scrolling social media or just laying in bed taking naps, and not really being, in that retrospect, very advocate for myself.
Yeah. Okay. Okay. So there's not really that motivation, and you're feeling really lethargic, and like you don't really want to do much. So tell me what your day-to-day looks like.
Yeah, so I mean, my day starts, I don't really set an alarm. I don't have a job, so no reason to. And kind of whenever I get out of bed, I usually eat. Sometimes I eat, sometimes I don't. Then I kind of just find something to fill the day, and if I didn't eat at like a lunch and then I'll go through the whole afternoon, I try and do my best to eat a good amount of food for supper just to recuperate, and then find something to do, I guess, for the evening and then try and go to bed. Usually, sometimes don't go to bed for a while, but you know, that's just patterns in that retrospect just changes. And no real rhyme or reason to that.
So it sounds like your eating habits are a bit different, and also your sleeping patterns and everything's kind of just shifted.
Yeah.
Okay. So what was it like before, like your eating habits, for example?
My eating habits before, they were fairly regular, like in a regular time schedule. Because of like the university I went to, they would have like times for lunch was served and times for supper. And so like those patterns were really nice to have in place. Pertaining to my sport, just because of how wrestling was, you kind of have to make weight. And so sometimes you don't eat a lot just to get down to a weight. If you're a couple pounds over, you might practice extra hard, try and sweat it out. But there have been times where me and some of my teammates have been like 10 pounds, 12 pounds. And so that's when you have the more extreme measures of like wearing a trash bag, going into a sauna and trying to sweating it that way, or you can use laxatives just to clean out the digestive tract and hopefully get you a couple of pounds that way. And so like those are the things that have kind of, I would say impacted, but reflecting on it now, it wasn't anything out of ordinary, because you know, like we'd have practice, you would go eat, or you would eat and then go have practice, and so you had those times.
Yeah. So now, so before, excuse me, it was a little bit more regulated, like you had a more a consistent schedule, and then you eat at regular times. And it also sounds like at times it got pretty restrictive, where you couldn't eat and you don't have to, like how you said, take laxatives or try to take more extreme measures and like go to the sauna, sweat it out, things like that.
Yeah.
So I'm wondering, when you say that your eating patterns have been different, if you're experiencing some of those restrictive eating patterns again.
Maybe, but I think it's different though. Like,
okay.
I feel like it was justified in the past of like, this is just like how you be your best at your sport. And now it's kind of just like, I don't eat because I don't feel like it, or I eat way too much because I feel guilty about the times I didn't eat that week or that day. And so I have just, yeah, I feel like it's just different, and it's, yeah, no purpose, and it just is what it is sometimes.
So you said right now that you'll eat more, right, at certain times.
Yeah.
So is there like a pattern of eating more at different times, or like tell me more about that part?
Yeah, so I mean, obviously it could like shift, but if I had to make it an average, like standard type of way to track it, it would be probably at least either whichever every 2 weeks or once every 2 weeks. And then, but I don't know if you can really track that in that sense, because it only started, like that type of pattern of really like eating a lot in one sitting only started maybe like 3 or 4 months ago. And so I don't know if that is like, if you can actually like really say, oh, I can think of like going back, and if you can say it's like, okay, 2 weeks it would happen. But sometimes it's like less than 2 weeks, like maybe it's a couple times a week sometimes. And so that is, yeah, it's been really hard for me to track, at least right now.
Yeah. And so when you say that you eat a lot more, right? Like I'm wondering if, are you doing that like is that normal for you, or is that something that's new? Because you said 3 to 4 months ago this started, right? And that's about the same time you graduated?
Right. Yeah. And so, I mean, comparatively it's completely new and different
Mhm.
because I had the like 4 years of consistent as an athlete, and then this shift has been, it's, yeah, I would say it's completely new.
Yeah. And so when's the last time that this has happened?
Like just the eating a lot.
Mhm.
I want to say within the last week.
Okay. And when you say a lot, like what does that look like? Because I imagine for athletes that's different, right?
Yeah, I think it looks more to like, maybe you see like an athlete and it's more food, but it still fills them up and they feel fine.
Mhm.
I think for me more recently it's been like I eat, but then I eat more and I don't feel good after. Yeah, not necessarily, yeah, don't feel good, but also like a lack of control.
Okay.
Somewhat, just like, oh yeah, I have a plate, but there's like, I want to eat more, even though maybe consciously or unconsciously I know it's not gonna feel good in the end.
Yeah. So you don't feel good afterwards. And then
Right.
it feels like you don't have that sense of control.
Yeah, I just feel like not moving, sleepy, all those things.
Okay. And so, you said this is relatively new, and I know also when you first came in and we filled out all the paperwork, you said that you've never been to counseling before, is that correct?
Yeah, this is my first time.
Yeah, okay. And so, okay. So whenever this happens and you feel, uncomfortable and, so I'm wondering if you do any like compensatory behaviors, like if afterwards maybe you exercise or, how before you said you would use laxatives, is there any of that behavior going on?
No, that hasn't been like a thing I've resorted to because I think personally for me it's just like I just feel bad and I don't want to do any, like I just feel bad and feel like I can't do anything about it.
Right.
Yeah.
Alright. So then I know we're out of time for this session, so next week we'll pick back up on this.
Yeah.
And we'll talk more about it, okay?
All right.
Thank you for coming in.
Of course.
Okay. So we have about 15 minutes, y'all. But right off the bat, what are some symptoms that stood out to y'all?
The sweating it out, behaviors like bulimia nervosa almost, excessive working out.
And Santi, what did you say?
That was definitely at the time, like the words leaving my head, like the behavior, like to rid of like the food or like what they were thinking. Um, at the time he was playing a sport. Laura said it in the chat, like recently it's skipping meals and then like making it up later, eating and things like that.
Yeah.
You talked about being in control also. Sorry, Santi.
No, you.
Yeah, so the sweating it out and the, taking laxatives, that was definitely part of him being an athlete. So just remember that part. And what's different now is he did say that that was before and it's not happening currently. So I'm just going to point that out because it is a little hard to hear. But yeah. Okay, anybody else? Anything else that stood out to y'all?
I don't know if this is really a symptom so much as we were talking about some eating disorders being competitive and the fact that he was an athlete and a very competitive one. And I'm wondering, if some of that might play into the current issues that are going on.
Yeah, so it's definitely something to look out for. And Laura said also feeling guilty after overeating and loss of control. Okay. So when we hear that, what are some questions that you might want to ask if you were trying to further assess, right? So that kind of goes into what Nora was talking about is like if we're so we know that what symptoms are kind of standing out to us, but then of course he was an athlete and maybe is no longer struggling with identity, right? So what are some questions that you might want to ask before you even start to provide or think about providing a diagnosis?
Maybe like what are you feeling during? You know, like are you being flooded like when eating? Um, I guess in what he kind of described as like excess. Are you being flooded with like good feelings, with dopamine? Obviously, we feel guilty afterwards. So, how long are the good feelings lasting? Is it solely just while you're eating? Is it a little bit afterwards, or is it just instant remorse once you're done?
Mm-hmm. What else, y'all?
I know that there's like a loss of identity, but overall, like, because a lot of it is depressive symptoms. So I just wonder, like, overall, what's just your self-image right now? Because we have our loss of identity, but like, you could still feel good about yourself in different ways, and still try to find that thing. So I would go into that.
Yeah. Okay. It's loss of image, identity loss for sure. And you mentioned depression. Yeah.
Maybe if he's experiencing any grief.
Grief.
Yeah, maybe like I guess again with that loss of identity, loss of a previous lifestyle.
Yeah. 'Cause that's a big part of people's lives, especially college athletes. Like there's a whole body of research on this. In the chat we have asking how often he thinks about food or body composition. Also how these behaviors have affected his life, socially, eating, etc. Yeah.
He mentioned guilt, bringing up the aspect of shame, maybe, like, or try to work a way around it, because that was um mentioned as a like a symptom for eating disorders. So is there shame in that loss of identity? Is there shame in your relationship with food now? Or in what you're doing currently? So
Mm-hmm. Yeah. Shame and guilt, asking further, right? Because it's just a 10-minute clip. I mean, the sessions aren't, and we're going to be working with this individual for a while. Also, what are some other considerations like that are pertaining to the client, right? So just because somebody, like Nora said, that the identity, actually most of y'all said that, right? The identity loss. And he was an athlete. So what are some other considerations in this case, right? Also first time. Just keeping that in mind, like what might be some other considerations for him, whether it's cultural, anything like that.
What does a support system, or what do his support systems look like? Like, are you still in contact with athletes you used to play with, or are you in like I don't know, our life after, I don't know, being an athlete support group, stuff like that?
Yeah, support system.
he mentioned being unemployed currently. So I wonder what resources does he have on hand, given his situation. I don't we weren't made aware of his financial situation, but like look into that. Like what resources do you have on hand given that right now you're still looking for a job? And what his cultural and family values are on his current employment situation and how that can feed into like the identity and the guilt.
Yeah, so maybe we see on the outside there's not much of a support, but if he's not valuing that, then it's like, oh, okay, well, then that's probably not something that's important, or it could be. So that's good, something good to test for sure. Anything else?
I
Any
think
patterns or
also
triggers in their
express.
environment? Mhm.
Oh, go ahead, Dom.
Good. I was thinking about motivation and if he has any current goals, just to see if those goals are focused on body composition or if he's currently like practicing any type of athletic practice, like maybe if it's just working out in the gym, just to see if like he is working towards something, and that could be addressed, whether if it's maybe disordered eating or if he's like going for competitions, things like that. Because a lot of athletes do transition into a different form of like weight training. So I'm wondering if that's something he's experiencing. And then that grief piece, like he's losing something really a big part of his life and what's next for him.
I was gonna read the comments and then I was also gonna say something. So in the comments they're saying the beliefs about health, acknowledging the overwhelming sense of change that he's experiencing, any patterns or triggers in the environments when he overeats. And what I was gonna say when you were mentioning about the cultural stuff, like in looking into his intersectionality, like as a white cisgender male, and how all of these behaviors were at some point normalized, almost like needed or expected from him because of his sport, and um if whether or not like people are actually seeing them as abnormal now or not, since again him being like a cisgender male who used to be an athlete, right? So
Yeah. Yes, very important. Thank you, Sharon. Intersectionality. So assessing for that. And now that we have a few minutes left, so I know we're kind of flying through this, but what do y'all think the diagnosis is and why?
Because the like compensatory behaviors are no longer in effect or like going on, I would say that kind of rules out currently, or like a current diagnosis of bulimia nervosa. So maybe it's more so like major depressive disorder, especially with the lethargy and loss of energy he reported to.
Yeah, I definitely agree with Kendall there. I was thinking like maybe before there would have been a qualification, but right now it seems like the depressive symptoms are what's causing the like unhelpful like eating habits. Maybe with like the further evaluation we just talked about, then we could have a better idea. But that's what I was thinking.
I think we could specify like an F code to put like restrictive eating as well, because I think it's important to kind of mention that he does have like those patterns. But I also agree.
Or even the other, oh, I forgot how she had other unspecified. We could categorize it as that until maybe you'll have further sessions. We get a little more like frequency, duration questions answered. But yeah, maybe other unspecified.
Okay. Anyone else have anything different? Okay. So we mentioned that it could be an unspecified or otherwise specified. I don't have what she said either. Eating disorder. There maybe potentially was some sort of binge eating disorder going on previously, but we don't have enough information for that, and also that was no longer happening. Because of the compensatory behavior being absent. We did talk about major depressive disorder. So of course, this was supposed to be like a eating disorders case study. And the other question was, what are some comorbidities? And y'all were discussing depression, right? I think originally, Sharon, correct me if I'm wrong, because we filmed this back in October for the original training. But we were going for potentially binge eating disorder, right? Because it started 3 months ago and he was engaging every couple weeks.
yes, it is like he is presenting enough symptoms. Like if you look at the DSM, and I know we don't know that like this criteria on the top of our heads, right? Like, it would be impossible for us to remember like all the diagnosis criteria. But if you do go into the DSM and look under the binge eating disorder, he does present enough symptoms to be diagnosed with that. I know that the good counselor in us is like, okay, let's just wait and see, you know, like get to know them better, assess better, and that is awesome and great, right? It's really good practice as well. But he does actually have enough symptoms for a diagnosis. But I know we also didn't talk much into like the different specifiers between the different eating disorders that we have in the DSM, but I think it's something that maybe y'all can look into later on in the DSM, kind of like trying to be more familiar. Because even when we did this case study, we had to go back and look at the diagnoses and criteria and stuff. So, but yeah, definitely the comorbidity with the depression as well. Definitely very, very prevalent there.
So, thank you, Sharon, and thank you all. That was actually all we had. We did go through it really fast, only because, again, the time did kind of catch up to us. But what other questions or comments do y'all have before we're done for today?
How long, because it's already the end of the semester, and I know usually when we check things out for Tex-CHIP, it's like end of the semester thing. So if we get the book from y'all, like, can we keep it through the summer semester, or what's y'all's time frame for that? The book that y'all had mentioned earlier.
You're an internship one, right?
Yeah.
Dr. I.
Yeah, I think you'll be fine to have it through internship too, honestly. Anybody new who's starting Tex-CHIP won't have this training because they'll be starting in the summer, right? So as long as, you know, we're able to loan you the book until your last field experience semester, you should be okay.
Okay, thank you.
Thank you.
Welcome. Well, I want to thank you all so much for your participation and engagement. And thank you, Bethany, for facilitating the role play you did with you and Justin, both of you. Y'all did a great job.
Thank you, Sharon, for filming. We were trying to do a point of view, so she was behind me. So obviously this is not how you would show your internship or practicum tapes, but you know, it's trying to be from like counselor's point of view to what you can see, but you know, our filming skills will get better. So
Yeah, that worked. That was cool.
thank you. So I think we're good to go, Dr. I.
Yeah,
if you have any questions, just email us.
Yeah, we're good to go. Feel free to send us an email and remember to pick up those books.
Thank you.
Y'all have a
Bye,
good
everyone.
one.